Hi, everyone. How you doing? Let me fix my setup real quick. Hi, everyone. Hopefully everybody can hear me well. Happy Friday. Everything's off here, it looks like, but it's okay. It's not off, it's just different than I'm used to. I tried to set it up different, but I'm going back to what I like. There we go. And let me just make sure my computer doesn't fall on us. I think we're good to go. How's everybody doing? Happy Friday. Hopefully everything goes good today. Can everybody hear me well? Let's get anything out of the way that we need to as far as being able to hear me. Who's here? We have Birdie. What is up, Birdie? Hi, Cup You. Harlot's in the house. Twisted Crime Tales. How you doing? Heidi's here. Hi, Heidi. Oh, look, a squirrel was able to join us. Jen Pop Elwop, how are you? Ivy's here. Coca-Cola. Oh my gosh, you guys. This is great. Who else do we have here? Hey. Hey, Higgins, how you doing? Hi, hey, Higgins. You guys, tell me where you're coming in from. I'd love to hear it. Where are you tuning in from? That's exciting. How's everybody doing? Is everybody watching this trial? This trial is, oh, it's hard. It's hard. And I think that there is a lot to learn in this trial, especially because I thought it was interesting. We're going to see today how the defense brought up the DSM. I could not believe. Did anybody else catch that the one psychiatrist didn't know what TR stood for? I was like, wait, what? I rewound it because I was like, I heard that wrong. She did not just say, I'm not sure. But she did. But it's okay. She's a very smart lady. We're going to forgive her for that. I just thought it was a little bit like, but it stands for text revision. So there wasn't enough to revise to make it an entirely new edition. So they revised the old text. They did it with the 4th edition as well. But we are going to be coming up when a DSM-6 says the defense. So look out for that. So, oh yeah, let me put it. I'm so glad you said that, Cuff You. I always remember to put it on all chat, and for some reason I didn't today. So thank you for reminding everybody to put your chat on all chat, not top chat. I always wonder, like, who chooses what top chat means? Like, what does that mean? Huh? I don't know. Who didn't know text revision? Oh, one of the one that went on today, the psychiatrist. Not a psychologist, a psychiatrist, which was a little more alarming, in my opinion. But yeah, it was the first psychiatrist today, but we're going to go over it, so you'll see. I don't know if I clipped that exact part, but I'll show you who it is when we get to it, because I'll never forget it. Okay, so hopefully everything is running with the internet and all the things. So hopefully everybody can hear and the volume's good. And when I play clips, I'm hoping that that all works. So you guys just let me know. We'll figure it out. Oh, Ivy, thank you. Wow, Ivy is... Where are we at, Ivy? Here you go. Ivy, thank you. Wow, Ivy's starting us off today with some jewels. Thank you, Ivy. I do appreciate you. I'm taking a sip of my drink before we start because I am so thirsty and I don't know what it is, but I don't know. And then I'll find that I won't be like paying attention towards the end of the live, like my meds are clearly worn off, and I'll just take like a big drink, and I'm like, meanwhile, I'm like so cautious of it, and then I'll just take a big drink, but that's what I'm doing real quick. Hi, guys. Wow, Ivy, thank you so much. All right, here I come. I'm back. One sec, here I go. Bucket Pinata, how you doing? Welcome in. Here we go. This is going to be hard because it's a very touchy topic. Not touchy. I shouldn't say touchy. That's the wrong word. Let me take that back. It's under discussed, in my opinion. So we're going to look at this. I think we also, you know what? I'm not going to get ahead of myself because I have an entire thing that I've been preparing for like 2 days now. So we're just going to do what I prepared. So let me attach these slides and we will get going. Puff, you said, oh, it's touchy, very. It really is. And, you know, I get it. And I also get that everybody here is going to be respectful of each other's opinions. We can all have different opinions. A. Higgins. We can all have different opinions here and discuss it. But in my heart of hearts, this is like very clear for me personally. So, but I am still willing to change my mind. So if for some reason, you know what I mean? Like I am willing to change my mind. I'm not saying that. I just, as of right now, I think the more testimony I hear, the more I feel that my position is validated. Oh, Ivy, thank you again for the jewels. Oh my God, thank you, Ivy. That is so generous of you. I appreciate you so very, very much. Okay, let me share this. Let me add this to the stage. So, in my thumbnail, I'm assuming, you know, you guys noticed that everyone here is looking away. So these are, as I was preparing, I noticed the theme and I'm like, there's women, a lot of women, psychiatrists and things, you know, medical, there's one other. So there's the general surgeon, but I believe the rest are psychiatrists. We'll get to it when I get into my notes. But, you know, what did they see? What did they see differently? What did they perceive? Did they misperceive it? Did they, you know, perceive things correctly the way that they saw it in that time? Because all that is very, very possible. You know, I'm dropping shit. Sorry, guys. Hold on. There we go. Sorry about that. I can't see over here. I'm trying to get my notes up. Here we go. Okay. So with the with this, let me make sure you guys are saying, okay, you're saying what I want you to say. All right, here we go. So I don't know why it just pulled up the wrong thing. Here we go. Now I'm good. Okay, you guys, let me start this. So again, everybody's going to be, you know, you guys know the rules. I don't have to tell you. You're not children. Okay, so I have my personal hypothesis or thesis or whatever you want to call it. But the question for me, you know, we're going to see how they talk about looking organized and stuff like that. And, you know, it's not really about that for me. The question is what their point in time evaluations captured. So how did they capture it at that moment? So not today in hindsight, not after the fact, but in that moment, because I think that that's important. I also want to make sure that, you know, I'm cautious and cognizant of the fact that hindsight is 2020, right? So we have to keep that in mind. We need to remember that, what did I write here? I have my little notes here and I wrote, oh, we need to capture, like, or we need to question what did they depend on for their diagnoses, what was disclosed to them, whether the records support a postpartum psychosis diagnosis, despite, you know, I mean, she's had repeated visions and no psychosis was observed. So I'm going to try to give and do my best to present both sides of the argument. However, if I'm being true to myself, I feel as though I lean heavily in postpartum psychosis. And I just want to be honest about that right from the start. So the thumbnail here gives us a visual metaphor. Lindsay is centered while the clinicians are looking in different directions. I did skip past that, but let me show you that again real quick. Okay, so for me, this was used as a metaphor. I did this as a metaphor, not as a snapshot or anything like that, not as an accusation that they literally ignored her. This was just my interpretation of how I was feeling when I made this thumbnail earlier. So my position for this live can be candid, but bounded. I think postpartum psychosis is a serious hypothesis that this testimony makes more, not less, important to examine. I am especially interested in Tufts' repeated notion of poor insight. That got to me so bad today. So poor insight is not a synonym for psychosis, right? So, and Tufts explained that she meant Lindsay's appraisal of her own anxiety and medication effects was why she was saying that. We'll get into that more, but whew. So I'm not going to turn, her note into a diagnosis that she didn't make, but we're going to talk about it. So let's start. Where should we start? Let's start. Okay, so this is what I want you to do. Tonight we're going to look at week 2 for the most part, because I want to look at, the psychology stuff. There's many channels, many viewpoints, many perspectives, and this is the one where I feel like I can give back the most. So that's why I'm going to stick to what I know, right? So I want to ask the question, what happens when a severe psychiatric condition is developing between these different snapshots in time? So you're going to hear different pieces of testimony, and we're going to talk about the different doctors and things that testified this week. And also keep in mind that what they observed, it was very much so their perception, and it very much could be that Lindsay did not have psychosis yet. I do think that it shows a progression of her. We're going to see something. I found this doctor, I'm sure you guys might know who he is, but Dr. Joseph's. Anyway, he did this thing and I was like, oh my God, it was amazing. So I'm going to show you guys a clip of him too. That'll help me to explain what it is I'm trying to articulate when we talk about that. So tonight I want to spend most of our time though with 2 of the doctors, just because if we spend equal time on all of them, we would be here till tomorrow. So first and most importantly for me today was Jennifer Tufts, because she treated Lindsay repeatedly and saw her virtually on January 23rd, which was one day before Cora, Dawson, and Callan died. And let's keep them at the core of all of this and remember them. So then I want to look at I want to say her name right, Aaliyah Goodhart at McLean. And you guys have to remember, McLean Hospital is Harvard's hospital. It doesn't get, in my opinion, any better. We're talking about where John Nash went. This is a hospital that is so well regarded. So let's keep that in mind. And we're going to look at Lindsay during her January hospitalization, because it gives us some of the clearest testimony about sleep, diagnostic uncertainty, and collateral information and postpartum psychosis. I also want to explain a phrase from Tufts that jumped off the page at me, poor insight. Like I said before, I have taught this version of this concept for years. Insight for me matters because treatment depends partly on whether a person can recognize that something's wrong, identify their symptoms accurately, and understand the need for treatment and communicate what's happening. A lot of what is gathered for these diagnoses, you guys, is self, um, the person is telling us about their own experiences. So therefore, it is very important for the patient to articulate the best that they can what it is that they're feeling so that the doctor can help them in the best way possible. So what did I write here? Oh, okay. I want to also talk about what Tufts didn't say. That's what I wrote. I said say what Tufts didn't say. I write like little notes just so that I don't forget to say things. So Lindsay lacked insight. This was a quote. Lindsay lacked insight because she was, wait, hold on. What she didn't say, I'm sorry. What I wrote down was she did not say, and I put quotes, that Lindsay lacked insight because she's psychotic. I need to type these things out, but again, I spend so much time on this that it would just be so much more. But I'll figure something out, don't worry. But I want to put some I want to talk about this just for a second. We're going to move on, I promise, in a second. I just want to talk about why I believe that postpartum psychosis deserves serious attention in this case. So this is my interpretation before we get started. I'm not diagnosing anyone. I say that all the time, but I need to say it just for, purposes. So we're going to build the strongest version of that hypothesis from the testimony, and then I'm going to test it against the strongest counter evidence, which is repeated clinicians saying that they did not observe psychosis, the timing after childbirth was an issue, and organized functioning denials of wanting to take her own life or hurting somebody else, and then toxicology that doesn't read as a classic overdose type behavior. So that's how I'm going to try to frame this tonight, not as the doctors did anything wrong, or not that the medications did it, right? So I'm also not going to say that she looked normal, so everything was fine. So I want to look at it that way too. Evidence psychology and the limits of what we can know from each encounter is going to be important for us to remember here. And just so nobody clips me out of context, I am a psychology professor. I've been teaching at the college and university level for over 22 years. I have experiences in many areas. I just, for the sake of the live, I'm not Lindsay Clancy's clinician, right? I'm not diagnosing her. Criminal responsibility is a legal decision that the jury will make under the judge's instructions after hearing the evidence that we haven't even heard in full yet. So there's still so much evidence that we haven't even heard of yet. So let's real quick talk about the DSM. So the DSM, because this is brought up, I'm going to make it real, quick, and then I'm going to jump to the first clip that I have, which is going to be of Dr. Goodhart today on the DSM, which let me just make sure I have this clip real quick. My little clips here. Okay. All right. So the DSM is the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders. So the 5TR means the text revised revision of the DSM-5. So clinicians use it as a diagnostic tool. So it's a tool, you guys. It gives the criteria, the descriptions, differential diagnosis information, and even things like coding guidance for insurance purposes. It's not just a blood test. It doesn't replace history observation, collateral information, or clinical judgment. That point came out in court from Dr. Goodhart herself. So let's jump to the very first clip that I have here. Okay. It is 333. Oh, that's crazy. It's at marking was held medical. Ooh, let me pause that while I get it. And let me just put it so you guys can see it. Hopefully it all works out. Fingers crossed. Let me share. Okay. I'm just removing this and sharing something else real quick. You would think I'm like an old person. I don't know. Share screen. Here I go. All right, we should be all like attached to the volume and everything. Hopefully it all works out and everybody can hear everything. I'm going to mute my mic while it's on because, well, for obvious reasons. So this first part we're going to hear is about what I was talking about when it comes to which is like, close that out to make it bigger.
Conversation of bipolar disorder, bipolar disorder 1, having major depressive symptoms or episodes, as well as psychosis.
Yes.
And it's very brief mention, but it's in here. Patient to cheat ever. You were asked some questions about the DSM-5, and I actually have a version of the most recent version, the DSM-5 TR, meaning text revision. You're familiar with this book?
Thank you for clarifying that. Yes.
And counsel asked you some questions about postpartum depression and postpartum psychosis and whether they appear here in the DSM-5.
Yes.
Recall that line of questioning? And fair to say they do appear. They're not their own category, correct?
Yes.
But they do appear in conversation of bipolar disorder 1, having major depressive symptoms or episodes, as well as psychosis.
Yes.
And it's very brief mention, but it's in here. Is that correct?
Yes.
And as a psychiatrist, this is just a tool that you could use.
Yes.
What other things do you rely upon when making a diagnosis other than a tool like this?
Observation of the patient, the history that they're relating, the information from family and other, that's essentially it, and other records if available.
Okay, and you use that information based on your own training and experience
Yes.
to come up with a diagnosis.
Yes.
Okay, so that was the first part that I thought was interesting. So it's a perfect foundation for, making this point here. So Goodhart says that postpartum depression and postpartum psychosis appear in the DSM discussion, but that they're not standalone categories. She also says that the DSM is one tool amongst, observation, patient history, family information, and other records when they're available. So the current clinical literature matters here. So postpartum psychosis is recognized as a psychiatric emergency, even though, as of the recent expert consensus literature, it does not have its own standalone DSM diagnosis. And that is so very important that I think people need to understand. So it is not its own diagnosis. However, it is mentioned amongst other diagnoses. So it is in there, okay? It's in there. It's just not as its own standalone. All right. So what else am I going to put here? Okay. Also, it's strongly associated with severe mood episodes, especially bipolar spectrum illness, and can involve mania, mixed states, severe depression with psychotic features, delusions, hallucinations, paranoia, agitation, disorganization, and impaired cognition, which is just an impaired thought process, right? So here is the timing caveat for us. I don't want anyone to bury classic postpartum psychosis usually begins very soon after delivery. So that is one thing that is in there. However, it doesn't mean, I've been researching this so much, and there are cases, so many people who have symptoms that are that they thought were things like the baby blues, stuff like that, things that they thought were considered normal after delivery. The thing is that they got worse for some people instead of subsiding. So large studies, you guys, that I was reading on and reviews, they commonly place the onset in the first days to weeks after postpartum. Lindsay's youngest child was about 8 months old on January 24th when his life was taken. So that makes the case seem clinically unusual. However, we do see signs that she sought help a lot sooner. So is this something obviously that increased over time? So usual also here does not equal impossible. We have to remember that, but we shouldn't pretend that 8 months is the classic onset window either. When experts testify later, I expect timing, onset symptoms, and whether an earlier mood episode evolved into psychosis, to be fought over heavily in this case. I mean, that is pretty much at the core of the case. The APA describes postpartum psychosis as rare, right? Roughly 1 or 2 cases per 1,000 deliveries, right? 1 to 2 cases per 1,000 deliveries. And potentially it involves insomnia, excessive energy, agitation, voices, paranoia, and suspiciousness. Okay, many affected women have a personal or family bipolar history too. That was something else that I saw that was common amongst the literature. It's an emergency risk, and it can be very, very severe. So let's not take those symptoms and, you know, just be like, okay, like, let's play bingo. This is like what here. That's not what I'm suggesting either. So insomnia is not psychosis. Anxiety alone is not psychosis. Depression isn't psychosis. Being postpartum isn't psychosis. The question is whether the full pattern, the course, and the eventual reported psychotic experience fit an expert-supported diagnosis. One final concept before I continue with the court clip. Insight is multidimensional. In psychiatric research, again, I've been researching this heavily the past few days. So in psychiatric research, it can mean awareness that one is, so this is insight, this is what I found, that in psychiatric research, the word insight can mean awareness that one is ill, awareness that experiences are symptoms, understanding consequences, and recognizing need for treatment. Research in psychotic disorders often find that poor insight is associated with a poor treatment adherence or functioning, but the relationship is not simple, and most of the literature is not specifically about postpartum psychosis. And so that's important. It needs to be studied more. So when I say tonight that poor insight matters, I mean, it's clinically worth interrogating, in my opinion. I don't mean that Tufts wrote down the secret diagnostic key to the case. Now let's get into McLean, because Goodhart gives us the biggest setup for what the outpatient clinicians were facing when Lindsay returned home. So this next one is Dr. How do I say it? Aaliyah. I don't know why I'm like trembling on that one. Aaliyah Goodhart. She is a psychiatrist who testifies about Lindsay's January 1st through January 5th at McLean admission. Her testimony is important precisely because it cuts both ways. She takes sleep seriously. She considers the postpartum context. She discusses bipolar risk. She also reportedly says that she did not observe psychosis. So that's also important. So let me jump to that clip real quick. 135. All right, here we go.
What did she identify to you to be her main concerns that she wanted to address during her stay at McLean?
She did not want to be dependent on an antipsychotic medication, which is what Seroquel class is, even though it's used for insomnia and other indications, depression. She didn't want to be dependent on Seroquel to be able to fall asleep.
Okay, and so fair to say she was very concerned about wanting to sleep at night.
Yes.
And she was very concerned about her symptomology, or what she was experiencing by way of symptoms from various medications, right?
Yes.
And that concept, or the phrase numbness, did she use that a few times?
Yes.
And again, you mentioned Dr. Madva was concerned about the numbness with the medication. In your experience with Seroquel, is that also a common side effect for people to feel numb?
It can be one of the side effects that people can have.
And as far as the suicidal statements that you were aware of from the prior reports, did you go through that with her about whether she presented to you with suicidal ideation?
Can you ask me that again?
Sure. Did you talk to her about her thoughts of suicide?
Yes.
And did you talk to her about whether she had any specific plan?
Yes.
Did she have any plan?
No.
Had she reported that she had ever had a plan for suicide?
No.
And did she tell you there were reasons why she thought she wouldn't commit suicide?
Yes.
What were those reasons?
Her children and her family, her mother.
So after this face-to-face interaction with her and kind of going through her history and having reviewed what you had, the information you had about her, what did you develop as a plan for her while she was at McLean?
I continued with the plan to taper her off Seroquel and to monitor whether her symptoms improved, but also to see if she could sleep while she was off of Seroquel. And to really observe symptoms and mood.
Okay, you guys. So cuff you, yes, you're right. There is a lot more cases, or is there a lot more cases, is what I should say, of postpartum depression, or are we more aware of it? Also, I think it's important to note that postpartum depression is very common, but postpartum psychosis is not. So that's also interesting. So I don't know, but I do agree with you. I do think that we see more cases of it. My question is it more common, or do we just know the signs more? Are people more willing to talk about it? I'm not sure. That has to be a study in itself. Bucket Pinata says that Lindsay had taken medications when she was in nursing school. That's absolutely right. That comes out today in the evidence as well. And we also know that she was struggling with depression after her other two pregnancies. So, it's also, if you look at psychosis in postpartum, we see that the more pregnancies a person has, the more the symptoms, or the stronger the symptoms become. But I believe I read something about that in there tonight. So I'm not going to get ahead of myself. What I want to say here is that what Goodhart just said is stronger than simply just saying she had insomnia, in my opinion. So Goodhart's describing a clinical plan. She wants to taper the Seroquel, watch whether Lindsay can sleep, and monitor what happens to her mood and symptoms. So she acknowledges that severe sleep difficulty can affect mental health across diagnoses, which is true. And right, a lot of people know that. Think about when you're exhausted. A lot of things are you'll have a difficulty driving. Just anything you do becomes harder at that point. So here, the doctor acknowledges that severe sleep difficulty will affect the different diagnoses, and that it's clinically relevant when bipolar illness is being considered. So not diagnosed yet or anything, but when being considered. So I want to underline a distinction we heard from the doctor too. Insomnia means that you want to, and that you need sleep, and that you're not getting it adequately. Okay. A decreased need for sleep, and when we talk about this in this field, does not mean that you can't sleep adequately, but you want to sleep. When we hear decreased need for sleep, this can occur in mania and hypomania. It's different, you guys. So somebody may sleep very little without the expected fatigue. So this is like, I didn't need the sleep. I've been awake for 48 hours, but you're not, you could probably report saying that you're sleeping inadequately if you have the insight that, you shouldn't be awake for 24 hours with no need for sleep. You could argue that, but at the same time, a decreased need for sleep, you don't have that same tiredness and fatigue that you have with insomnia. Okay, so the lawyers sometimes use not sleeping as though those two phenomenon are interchangeable. They're not. So I wanted to make sure that I made that distinction. Now let's listen to the part that's hardest for my own postpartum psychosis hypothesis. So this next part we are going to jump to 142. And I saw people writing in there. I am reading as we watch these parts about knowing people. I've heard so many horrifying sorrowful stories to you guys. I really have.
She stated that her husband had concerns about her being on a benzodiazepine.
During this interaction with her on the January 3rd, did you observe any signs of psychosis?
No.
And in the notes and the interactions with the providers prior to your meeting between January 1st and January 3rd, did anyone ever note any symptoms or concerns for psychosis?
No.
And you're aware that Ms. Clancy was also still in that, what was considered the postpartum period, right? She had had a child in May of 2022.
That's a tricky question to answer because different organizations or agencies assign postpartum a different length of time.
Okay, and so in your training experience and your experience as a person who diagnoses,
yes.
Did you consider postpartum as part of what you had to figure out here with this patient? Or was it really not a consideration?
It was.
Okay, and why was it for you?
I mean, she had a child, and the risk of postpartum depression, postpartum psychosis is a serious consideration.
Okay. Now, after this first...
Okay, you guys, so Goodhart says that she did not observe psychosis on January 3rd and that the clinicians before her had not documented it during their admission. She also says postpartum depression and postpartum psychosis were serious considerations. Then she does something I respect. After one meeting, she doesn't want to pile on a new diagnosis because the label is available. She explains that the diagnostics, what she wants with the patient, and that she needs more information. So this is like a diagnostic restraint. If I'm going to critique the system, I also have to acknowledge when a clinician's doing something defensible and careful. However, there is a problem. Why? I mean, for me at least. Did anybody know? Oh, how about that wasn't on? Wow, you guys. I definitely clicked it and I just didn't click it. I definitely apologize. So here, you guys, all I said is that oh, I hate when I do that. She does do, I didn't like that laugh that she gives where she's like, what she's saying here is she had a hard time saying that it was the postpartum period because different organizations refer to postpartum differently. So for example, one said that it was like the first year, but another one said it was the first 6 months or something. Don't quote me on that exactly. I believe she does testify to it though. But the point being is that she doesn't want to lie, I'm sure. So she wants to make sure that she is careful with what she says. And according to the criteria that she follows, she didn't know if you could say that she fit within that realm. This is my problem with that. I feel like these when we have the time durations for different symptomology for diagnosis, although it's a guideline, it's exactly that, a guideline. I think we need to use other factors that I listed earlier that I won't list again, but that I listed earlier, that we need to use other things such as what the patient reports, what we're observing, in addition to the diagnostic criteria. And so I guess what I'm saying is if there's like a differentiation, we're not talking about it was 4 years later, we're talking about a few weeks. So, and, what exactly are you could argue that she did have symptoms in the postpartum period. They just weren't psychotic symptoms yet, right? So that they started at one point and that they continued to develop. And in my opinion, and I feel like I found evidence of, and I'm going to show all of you that too in a little bit, that there could have been her brain, she could have been one of the small percentage of people that has a really adverse effect to like something like an antidepressant. And he's going to explain that more because he does a better job at that. So this is long enough. I'll leave that at that. Let me move forward. So this next part here is exactly what I pretty much just said. Oh my God, that's funny. It's literally what I just said. So hold on, listen. So we're going to jump to 211. Let her say it for us. All right, here we go. This next part.
Record system.
Well, the same medical record system is just so that you have access to MGH, you have access to regular women's hospital, because it's all part of some big computer information access you have. What about other healthcare providers? Can you get access to their records?
Not immediately.
Well, how about if you have a release signed by a patient under the HIPAA law? You know what the HIPAA law is, obviously, right?
Yes.
And just tell me, what does that actually mean, that a patient allows someone to look at their medical records?
Yes.
And Lindsay was very, very cooperative with you guys, wasn't she?
Yes.
Did anyone ever ask her to sign a HIPAA release for anyone to get access to nurse practitioner Gelada's records?
No.
How about psychiatrist Tufts records?
No.
How about nurse practitioner Paul's records?
No.
Who's Letitia Dukes?
She was a social worker. I think that Lindsay saw at South Shore at the perinatal program.
Okay. And do you know when she went to the South Shore, Rhode Island perinatal program?
I know it was prior to admission. I don't remember the exact dates.
Do you know what recommendations that she had received at that point?
No, other than the medication.
Do you know what medication she was actually on when she presented to McLean Hospital?
Seroquel and Valium.
What is it?
Seroquel and Valium.
Doctor, correct?
I believe so.
And when again, if you don't know, just say you don't know.
Yes.
Okay. And
Yes.
I think you made reference to the fact, and maybe the DA made reference in questioning you about the fact that she was looking for doctors for some type of medication or something. Is that fair?
That's a very vague statement. I don't know what you mean.
Okay. Well, actually, she saw Dr. Tufts because Dr. Tufts advertised that she was an expert in perinatal care, right?
Objection.
No rule.
Oh, sorry. I wouldn't know why she saw Dr. Tufts.
Do you know what medication Dr. Tufts prescribed to her?
From what Lindsay told me, yes.
What?
Zoloft was the first.
All right. So Dr. Tufts, according to Lindsay, provided her, Lindsay, with Zoloft, which is an SSRI, correct?
It's an antidepressant in that class, yes.
Okay, so when you say an antidepressant in that class, the class would be selective serotonin reuptake inhibitor, right?
Yes.
And that's pretty powerful stuff, isn't it?
I don't know what you mean by powerful.
No? Well, are you supposed to prescribe Zoloft or sertraline to a person that has bipolar?
I think it all depends on what you're seeing when you see the patient.
Correct. So it's important, I would imagine then, to be fair in your evaluation of this young woman that came to your hospital for help on New Year's, to find out what any evaluations were of her condition, her presentation, her symptomology, when she saw that first psychiatrist, Dr. Tufts, right?
Lindsay was cooperative and she was forthcoming. I had no reason to think that she would not provide us with what other providers thought, just like she told us that Tufts said she was worried about bipolar disorder. And
I'm sorry, I apologize.
Yes.
Tufts advised her that she was worried
no,
about
sorry, it was
Gelada?
yes.
Okay.
Sorry, thank you.
That's all right, no problem. And again, if you have records, you want to look at them, that's fine, because I know it's tough to have all this stuff in your head.
Yes. Thank you.
Okay, so real quick, you guys, a few things. Hi, Travis. How are you? Good to see you here. Welcome. I'm reading along in the chat. You guys are so smart over here. And yes, Dr. G Dr. Goodhart and I believe Dr. Tufts are both named in the civil lawsuit too. Does anybody notice she keeps giving these like smiles? I don't know what it is, but that's on a side note. But anyway, so Goodhart knew that Lindsay had thoughts of taking her own life without intent or a plan, but she testified that she didn't know about both hotline contacts being raised on cross. She also knew that sleep was a problem, but the defense pressed for additional details about how severe and prolonged it had been. She did not have all the outside records or releases from every prior provider as well. So none of this means that McLean's evaluation is invalid. It just means that we need to stop treating evaluated by a psychiatric doctor as synonymous with every relevant historical fact was known and every future risk was ruled out. So now the fair counterweight here, I have to watch too, because now Travis is here, so I feel like I have to put my best legal hat on, but I'm just kidding. I know you're not judging me, Travis. But Goodhart had a protective factor and actual inpatient observation window here that I think we need to take into consideration too. So if people aren't aware, if you didn't have a chance to watch this yet, this Dr. Goodhart is a psychiatrist from the hospital, from McLean, when she had her stay there. Dr. Tufts, who we're going to get to in a minute, I want to get to that in a minute, but Dr. Tufts is a doctor that she saw before she went inpatient. So they're two different environments, if you will. One's inpatient, one's out, though I feel like the prosecution, in my opinion, is trying to make it sound like she's like doctor shopping. That's not really what it is. When you go inpatient, you use the doctors that are that work with that inpatient program. So, and this was her doctor outpatient. So, we're going to see that too. I just want to make sure everybody knows that. What was the other thing? There was something else, but I'm sure it'll come back to me. There was something, but it'll come back to me, you guys. But let's just see real quick. So we're actually going to move on to the discharge. We're going to move on to the discharge follow-up factors. So that's at 147. All right, here we go.
Conversation with her again on that day, January 4th, about going home.
Yes.
And what did she say about that?
Originally, I think we had talked about discharge on Friday, and she stated that she was anxious being in the hospital, and that she wanted to be discharged so she could be home with her family and her children.
And so did she ask to leave earlier than Friday?
Yes.
And when she asked to leave earlier than Friday, what was your response to that?
Whenever I said she could leave provided she had psychiatric follow-up the next day.
And why did you do that?
I wanted to ensure that if she wasn't able to sleep that night after discharge, that she could speak with somebody about it so that they could come up with a plan to ensure she could sleep and to monitor how she was doing off the medication.
And was there a kind of a secondary reason that you had asked that she make sure she make an appointment before discharge?
Yes, it was also to assess whether she could think clearly and follow directions and get it together. We asked her to set up the appointment herself, and she was able to do that. She responded within an hour. She told the social worker that she had gotten an appointment, and the social worker had asked her for a fax number so that we could we could send the discharge summary, and she provided the fax number as well.
And now on this day that you had met her on January 4th, she reported that she slept well. Do you recall what dose of Seroquel she was down to at that point? Had she reached 0?
On which day?
On the 4th, when you saw her.
I'd have to walk myself through this. So I know she was on 75 milligrams the night of the first, 75 milligrams the night of the second. On the night of the third, we decreased it to 50 milligrams. On the night of the fourth, she would have been on 25 milligrams.
Okay. And fair to say that on the 4th, your plan was to continue to taper her so that she would be at 0 for Seroquel, take no Seroquel on Thursday night, right?
Correct.
And that she would be restarted on Ativan, and that she'd have the trazodone available if she needed it.
She was already on Ativan during her admission and was taking it at night. She also had trazodone, which is a sleep medication. It has sedating properties, so it can be used for sleep. So yes, she had that. She had the option to take that as well.
And so, did you have a concern about her leaving on Thursday the 5th without having monitored her at no Seroquel?
I did not have any concerns about her safety or her risk for anybody else.
Okay, but as far as from a diagnostic perspective, would you have preferred to have more information about her sleep patterns and her mood?
Yes.
Now, you said that you didn't have a concern for her safety. So what, in your time that you were with her, that you met with her, and all the information that you reviewed, what were identified as maybe protective factors that made you feel comfortable that she was safe?
She was, there's several things. She was future-oriented. She was clearly invested in her children. She was a caring mother, just like a caring mother. She had her parents around to help her. She had family and supports, being sure that she would have outpatient psychiatric care for follow-up.
Okay, so real quick, when you said that you sent me the message on Messenger, is that Facebook Messenger? And if so, which account? I am the worst, you guys. Not the worst, I shouldn't say it like that. I don't have Instagram. I don't know. I just got something from Instagram telling me to look at. But Allie, tell me, because Allie, do you have Discord? Maybe you could message me on Discord if that's possible. Hey, you two bad actors, how you doing? I did this for you. No, not just for you, but you said it the other night. I did it last week. I'm doing it again. I'm like, if that bitch wants to see another different live, she'll be here, and you're here. So there you go. There you go. Okay, so here you guys, Dr. Goodhart describes family support, investment in the children, future orientation, outpatient follow-up, no history of psychosis, and no reported homicidal thoughts during the admission. She did not believe that Lindsay met the inpatient safety threshold at discharge. Protective factors are not guarantees, you guys. They're pieces of a risk formulation. We should neither erase them because of hindsight, because remember, we talked about in the beginning, hindsight's 2020, nor should we treat these as proof of a crisis could not have happened later. And there is detail here that matters for Tufts, which we're going to see coming up next. After McLean, Lindsay promptly arranged outpatient follow-up. This is, is this really somebody that's trying to refuse care? No, she's going along with it. I did find it interesting that Dr. Goodhart said she was able to get it together. I was like, oh, I don't know that she really meant it the way that it came across, but I kind of was like, oh. This is the McLean picture, in my opinion. Severe distress is what I'm thinking. So, and you have to remember, she went to McLean to get help. So you don't go to go for inpatient treatment, in my opinion, if you're not feeling like you really need it, especially knowing that she didn't like to be apart from the kids. So the McLean picture for me was severe distress and sleep concern, postpartum context considered, no psychosis observed during the window, incomplete collateral, and plan for a very close outpatient follow-up. That puts us exactly where I want to spend the biggest part here on this live, is with Dr. Jennifer Tufts. So let's move on. Tufts is the witness. I would, first of all, didn't see Tufts. I was like, When she came up, I was like, oh, don't tell me it's this little girl. And that isn't, with all due respect, like, God bless her. I was like, oh, she looks so young. So that's what I mean. I wasn't saying that in a bad way. So Dr. Tufts, right here, this is, you guys, she had repeated contact with Lindsay. I think she's an important witness here. She treated Lindsay over roughly 14 visits. Most were all were virtual. I'm not sure if they were all virtual or most of them, but most were virtual at least. She was tracking Lindsay's anxiety, mood, sleep, medication response, her taking of her own life thoughts, homicidal thoughts, psychotic signs, and functioning. The first clip here contains the line that I want everyone to remember. Okay, so the point of the meeting and the poor insight. So let's get to it.
Yes. And what did you learn from Ms. Clancy about whether or not she had taken that medication?
She shared that she decided not to take it.
Did she tell you that she had picked it up but had decided not to take it?
Yes.
Did she tell you how she was feeling?
She said a little bit better.
And did she elaborate on that?
The baby was getting some more sleep, so she was also able to get some more sleep, and that helped her feel better.
And at this appointment, did you go through a mental status exam of Ms. Clancy?
Yes.
And what is a mental status exam?
So a mental status exam is an assessment of the patient at the point of meeting. It can change at different times, but it's comprehensive, referring to how the patient appears, how they cooperate, how they speak, how they describe their thoughts, how they're able to communicate with you, and what their mood is like.
And do you do that at every appointment with every patient?
Yes.
And so on the September 28th, 2022, when you met with Lindsay Clancy for that second meeting, did you do a mental status examination?
Yes, I did.
And what was the result of that?
So is it okay if I read it from the note, or do you just want me to?
There's no objection.
Go ahead, you may.
She was alert. She was oriented. She was appropriate. Her rapport, meaning how she worked with me, was appropriate. Dressed appropriately. Euthymic, meaning not depressed, not angry. Kind of a normal mood. Her affect was full. Her speech was appropriate. Her thought content and process were appropriate. She did not mention any hallucinations. At this point, I mentioned her insight was poor, her judgment was excellent, her cognition did not show any deficits, and there was normal psychomotor activity.
And why did you list that her insight was poor?
So I think that must have been related to the fact that at this point, she did have some very clinically significant anxiety. Usually when people come to a psychiatrist, they believe that their symptoms are significant and that a medication is something that might be prescribed. But despite these symptoms, she still didn't want to try the medicine.
And what is the difference between a psychiatrist and a psychologist?
Okay, you guys. So this was big, and I'm reading what you guys were saying there. There was something that I wanted to respond to, and then I just had an ADHD moment. Hold on. Oh, the prosecutor's bows. I did a post yesterday while I was waiting for my daughter to get out of her appointment. It's driving me crazy. I feel like she's trolling Lindsay, in my opinion. Anybody else feel that way? I can't take it. Bucket Pinata, I agreed with something you said. Wait, let me see what it was. Oh, never watched a trial where the prosecutor's witnesses has helped the defense so much. I agree with that. So this is what I want to say here, you guys. First of all, Tufts says a mental status examination is an assessment of the patient at the point of the meeting, and that it can change. That's huge for the defense, isn't it? Right? That sentence should be on its own slide tonight. I have slides too, and I can't keep up with going back and forth. I prepared to put the slide on like right now while I'm talking, but it's just a lot. Anyway, she winds up reading to us the examination report, which she had written down as alert, oriented, appropriate, euthymic, full affect, which was different than dysthymic, which dysthymia is a form of depression, not as intense. There's full affect, she wrote down, appropriate speech and thought process, no hallucinations mentioned. However, she put that her insight was poor, but that her judgment was excellent. This combination is fascinating for me because it destroys the idea that poor insight simply means globally confused or incapable. You can have an intact cognition and judgment in many areas and still have limited insight into the nature or significance of the symptoms. But let's write, you guys, right? Before I even move on. So isn't that the whole point here? Like, I feel like you, Bertie was just saying, I feel like it's doing help for the defense here, which I am okay with. Hi, Casey. Case, I was wondering where the hell you were. I'm just kidding. You're not allowed to have a life, Case. So, but we're going to listen here to what Tuff said. What she says that she meant. She said, at this early point, she connects poor insight to Lindsay having clinically significant anxiety while not wanting medication. Later on, January 23rd, which is the day before the day before everything happened, she explains it more as that she over attributed. So she said Lindsay's believing that her medications were causing symptoms that Tufts believes reflected depression. So I want you guys to keep that in mind. I made those 2 points, those 2 connections here. So on one sense, in the beginning, she says her poor insight, in her opinion, was due to having judgment. Like, she was able to have judgment in many areas and still have little insight into the nature or significance of her own symptoms. And then in later dates, so at the end of her seeing her, but right before everything happens, she says that it was more of an over attribution, which just saying that Lindsay believing that her medications were causing the symptoms that Tufts believes reflected depression. So this is where my opinion comes in, and I want to label it clearly. I think this notion deserved heightened attention because outpatient psychiatry depends heavily on what a patient recognizes and reports. This is, most of what we see here, whether in this case or in any, if you go to the doctor tomorrow for psychiatric symptoms, we're talking about a huge thing here of self-reporting. We have to report what it is that what your symptomology is. So if the clinician thinks that the patient's not accurately interpreting what's happening to her, that creates an information problem for me. And Travis, I'm curious to see what you have to say. But I will not say Tufts knew that Lindsay was psychotic, right? She didn't testify to that. In fact, she repeatedly testified opposite, in my opinion. Now let's watch how medication and symptom interpretation started feeding into each other. So this is at 5:52.
There isn't anything that stands out to me right now.
And I think that what you put on the October 3rd date was that her insight was still poor.
Yes.
It was that for the same reasons you described earlier.
Yes.
The next time that you saw Ms. Clancy, was that on October 20th, 2022?
Yes.
And what information did you learn on that date about whether or not she was taking the Zoloft you had prescribed?
So she told me that she decided to start the Zoloft.
And did she tell you how long she had been taking it?
For 1 week.
And did she tell you that the previous night she had increased the dose?
Yes.
And that's what was in the original prescription, correct? To take the pills at 25 milligrams for 1 week and then increase to 50?
Yes.
So if that had been done, taking the pills for 1 week would be 7 pills, and then increasing the dosage the next night would be 2 pills?
Yes.
And so that would be 9 pills?
Yes.
When she told you she increased the dose, she told you she now feels awful, is that correct?
Yes.
And what was it that was bothering her?
She was having increased difficulty sleeping. She had loss of appetite, diarrhea. She was feeling her mood was down. She was tearful and feeling very foggy and feeling very anxious.
Now, what is the lowest dose of Zoloft that you would prescribe a patient or could prescribe?
The smallest pill is 25.
And what's the highest dose of Zoloft?
200.
So she was on the lowest dose of 25, is that correct?
Yes.
And then according to what she told you, she had increased for one night to 50 milligrams. Is that correct?
Yes.
Did she also tell you she was scared to start something new?
Yes.
Is that in terms of another medication?
Yes.
So what was your discussion with Ms. Clancy when she's telling you that she's having these issues with Zoloft, but she's afraid to try something new?
So we discussed what to do moving forward. So we discussed whether it would make sense to switch to a different medication at that point. And at that moment, because of her negative experience with the Zoloft, she did not want to start a new medication at that point.
At this meeting with her, did you ask her if she had any suicidal thoughts?
Yes.
What was her response?
No.
Did you ask her if she had any homicidal ideation or thoughts?
Yes.
What was her response?
No.
Did you ask her if she was hearing any voices or seeing any visual hallucinations?
I'm not sure if I asked that in that appointment, but she was very clearly not psychotic.
And why do you say that?
Because of how I described some of the signs of psychosis that are on a mental status exam, none of those were present.
What was her affect during this meeting?
While we wait for that real quick, Travis, you just had me peeing myself because you're so right. I guess this is why my nickname's Straight A Stupid. So Travis said, tell of what? Of course she's testifying to the opposite. She's being sued by the father for missing it. I was like, oh yeah, duh. And then Harlot says a whole bunch of those meds they are prescribing her can cause psychotic reactions also. Harlot, wait till you see. I have something for us to watch, and we're gonna say it. They also have stopped prescribing psych meds after the first couple of bad reactions, if not the first. Harlot, ding, 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 ding. Why? Because it could, and again, you guys, we're talking about a fraction, like a tiny fraction of the people. So I do not want anyone to hear this or to listen to this and think that you shouldn't go for, help, or you shouldn't take medication, because we're literally talking about that, the part of the pamphlet where it's like the less than 1% type thing. So we're talking about a very few people. Hey, Queen Nancy. If they tried to shove all those different psychotic pills down my throat, I would not take them either. She was afraid. She was actually right, though, not to take it, because did this doctor not consider some form of toxicity from the drug? And again, it's very uncommon. It doesn't usually happen. But if it's put on the pamphlet that we get, right? So that means that it was seen during the clinical trials. When it comes to one thing, I know my research, and I teach research methods. I do research, all the things. I've done my research. I've published stuff like my dissertation and stuff. So that part I know. So I think that Lindsay reported Zoloft at 25 milligrams and then increased it to 50 as prescribed. But then she reported feeling an increase with difficulty sleeping, increased appetite loss, increased diarrhea, low mood, tearfulness, fogginess, and anxiety, all increases. Tuff says that she denied wanting to take her life or hurting somebody else, and that she was not sure that she had specifically asked about hallucinations at the first of these visits, but then testified that Lindsay was very clearly not psychotic based on mental status findings. I wonder if it's also based on Travis, our fabulous lawyer's findings as well, that she's getting sued. Of course she has to say a certain thing. Duh. I don't know why I wasn't thinking that, Travis. I'm still cracking myself up over here about that. So Tuff also did something important. She told her to stop the Zoloft and followed her closely the next day. So if I'm going to discuss medication harm, I want to be precise. The record supports an association, like a small one, between Zoloft exposure and the symptoms that Lindsay was reporting got worse. So that should have been taken into consideration. She should have listened to Lindsay more. Did she not? Is that what the argument is? Is that her thinking that Lindsay had a lack of insight clearly made her, fogged her perception, in my opinion, of what Lindsay was self-reporting. And that's a problem, right? So it also supports here that Tufts responded by discontinuing it. The record does not let me say, though, that Zoloft caused the killings, right, 3 months later. So I do want to say that. But could drug toxicity have played a role in her psychosis? I guess we're going to have to see. So let's move forward to December. The medication story is no longer one drug at this point, okay? So let's quickly jump to the 9. All right, here we go.
They can schedule it without my awareness. So she had scheduled it.
So she hadn't reached out to you in advance to ask about it. She just scheduled an appointment with you for December 1st, 2022. Is that correct?
Yes.
Okay. And
Real quick, before we go further with that, Cuff, what do you mean? I'm actually curious about Patrick. What do you mean? So do you mean because Patrick said, like, this is my thing though, Cuff. Patrick doesn't, he's an accountant or whatever he is. Like, I don't know what he is. I just made that up. He's not, that's not his job. So I think he calls and he complains, right? I don't know exactly what you were saying. So I am curious. I'm trying to catch everything here, but I don't know if I caught that in context. So let me know. But it's not really, you know, he looks like an accountant, says Harlot. That's why I said that. I don't know. You would have to go way back and chat. Okay, Cuff. Okay, I must have missed something because a lot of people are talking about that, not just here, right? So a lot of people say, you know, what about Patrick? Did he? But this is my thing. Even, you know, and again, I don't know, not in context to what you guys were talking about, because I'm not sure what you're talking about, but in context to what a lot of other people, like from what I'm hearing online and stuff, my only thing is that Patrick wasn't trained to look out for certain things, I believe, and I'm not positive, so someone let me know if I'm right or wrong, but I think he did report to, I don't know if it was Dr. Tufts, but to one of them, that the medication wasn't working, you know, whatever the case may be, but I don't know how far that goes, and I don't know if we're going to hear more about that. So let's continue.
And in that appointment, did she tell you that she ended up not returning to work?
Yes.
And what was discussed at that appointment?
That she wasn't getting better.
And in what ways wasn't she getting better?
She had tried the Ativan taper, but without the Ativan, she was having a lot of difficulty sleeping. So she tried a few different medications, a few different medication combinations, but she was having trouble with them.
And did she tell you what types of medication she had tried?
Yes.
And what were those?
Trazodone 50 to 150 milligrams was minimal effect. Ativan and Benadryl combination was helpful. Then she added the Prozac 10 milligrams with the Ativan and Benadryl to help with the sleep, but she still had worse sleep, so that was stopped. Then she tried a combination of Remeron with Klonopin, but she felt disoriented, had rebound anxiety, and it was of minimal help. Then she tried Remeron and Seroquel, and that was prescribed, but she didn't take it.
And these medications that she was talking to you about, those weren't prescribed by you, correct?
Correct.
Did she tell you that those had been prescribed by her provider at South Shore Perinatal Clinic?
Yes.
And what is Trazodone?
It is the category is an antidepressant, but the doses that we use are low, so it's really a sleep medicine.
And what is the lowest dose of Trazodone?
50.
And what is the highest?
It can go very high, up to maybe 600.
Okay. So the 50 to Prozac, I think you had said SSRI.
Yes.
And that was a medication Ms. Clancy had told you she had taken in nursing school, correct?
Yes.
With no side effects then? I told you on December 1st, 2022 that the Prozac had worsened her sleep.
Yes.
And then what is Remeron?
Remeron is mirtazapine.
And what's that?
It's another antidepressant.
And what is Klonopin?
It is a benzodiazepine like the Ativan.
So prescribing Remeron both as an antidepressant and Klonopin as an anxiety medication, is that an unusual combination?
No.
And then she told you she had been prescribed Remeron and Seroquel but hadn't started that. Correct.
So I think she had started the Remeron, but maybe hadn't started the Seroquel yet.
And did she also tell you, did she tell you what those intrusive thoughts were?
She said it was a feeling like I'm going to die.
Not a feeling that she wanted to kill herself, but a feeling like she was going to die.
Yes.
Did you ask her if she had suicidal ideation?
Yes.
What was her response?
So she denied having suicidal ideation, but she was feeling pretty badly. She said she was close to it, meaning close to having some suicidal thoughts, and that she was feeling very hopeless. But she didn't have any active thoughts of hurting herself, didn't have any intention of doing anything, didn't have any plans.
Did she also tell you, and this is a quote in the records on page 144, I think it's my problem. I keep reaching out to different people and not sticking with the plan.
That's what I documented.
And did you discuss that with her, that concern that she kept reaching out to different people and wouldn't stick with the plan?
Yes. I advised that she have one person who is managing the medications.
And why is that important?
So that it's very clear what's happening.
My only problem with this, you guys, is that the other person that was prescribing the medications was the doctor inpatient. So it's not like she was seeing like multiple outpatient doctors and whatever. So I do think, I don't know. But this clip, why is 13 medications, is as bad a headline, in my opinion, if it implies simultaneous ingestion. So Lindsay describes trying different medications and combinations through the perinatal clinic, which were the trazodone, Ativan, and Benadryl, Prozac, Remeron, Klonopin, Seroquel, being prescribed and sometimes not taking it. Tufts testified that Prozac worsened sleep, according to Lindsay. She also reports an intrusive feeling on Remeron, things like I'm going to die, while distinguishing that from wanting to take her own life. So by December, we have repeated help seeking, repeated treatment changes, persistent sleep difficulty, and a growing fear of medication effects. That sets up the poor insight disagreement in a way I think is psychologically important. Tufts believes that some symptoms reflect depression. Lindsay appears to believe some are being caused by the medication. If those two explanations diverge, you guys, what does a clinician do? What are you supposed to do, right? In my opinion, you assess, monitor, and change treatment when warranted. You have to gather history and try to preserve an alliance. There's no perfect laboratory marker telling you which interpretation is right, which is why this next clip matters. So let's go to this next clip. And this is about how important it is for disclosure. Here we go.
Which would mandate that they be brought to a hospital for treatment, or at least for evaluation and then possible treatment.
And did you feel that was necessary at that time with Ms. Clancy?
No.
And when you're evaluating a patient, taking the history, looking at their current state, looking at what the answers they give you to the questions, are you reliant on the information that they give you?
Yes.
So if a patient withholds important information, is it hard to make a diagnosis or a plan?
Yes.
Was your next appointment with Ms. Clancy on January 9th, 2023?
Yes.
And what was discussed at that appointment?
So she said that the trazodone increase was helpful. She was still getting that rebound anxiety the day after she took the Ativan. The mood was okay, but she was feeling like she was still flat. She wasn't able to cry, but she said she was able to laugh a little bit, and hadn't been having recent thoughts of suicidal ideation.
Had not.
Okay, so let me just go over a few things in chat real quick. So the one thing was about the eye flickering. Obviously, I don't know eye flickering. I'm not a medical, right? But what I could say is when somebody's anxious, maybe holding back tears, there could be many reasons for the eye blinking. I think that, I mean, you guys, we didn't get to hear it, but that 911 call from people who did get to hear it, they said, Nancy Grace was saying, I don't know if she got to hear it personally, but she was saying, you know, and apparently he didn't realize the phone was on him or still or something. So when he goes and runs in the house, and I don't know, you guys, I think it's terrible if anybody was trying to say that, like, you don't, I don't know what, like, somebody said that, like, the word, like, the conspiracy is that, like, she's covering for him, or like, that to me is just, no. Especially because he's moved on and gotten remarried since then. So why would, you still, do you know what I mean? You would think then you would be like, wait a minute, like, I don't know about that. That just seems far-fetched in my opinion. The other thing is, I don't know what it was in reference to. There was two other things. One was something, obviously you don't feel a hospital is necessary. I don't know, that might not have been to me. Butterflies, wow, thank you so much. Oh my gosh, you guys, there's so many things going off in chat. Let me try to get these one by one. We're gonna get through them. So real quick, I do want to say though, that is very generous of you. Butterflies, thank you so much. I appreciate you. Thank you for the jewels. Okay, getting back to this, I don't even know where to go with this. Birdie says Patrick's own father admitted that Patrick didn't help enough with the kids. Now this is my thing, you two bad actors. I mean, Birdie, I don't know why I just said you two bad actors. Birdie, do you know how many times I hear that? Like, I don't think that that's uncommon for one person not to help as much, or one person to complain about that. So, you know what I mean? Yes, I'm hoping everybody's being respectful. I think you probably are. Casey says Remeron alone is pretty strong. You were on it for a few years, gained a ton of weight, and it took months to be able to wean off of it. That's the thing that I think a lot of people need to remember, that a lot of these medications can cause a feeling of withdrawal symptoms when not taken. Not the same as, you know, but withdrawal symptoms nonetheless. So Cuppy says, this is hot and sometimes triggering topic. Dr. Vona asked that everyone be kind and considerate while sharing all thoughts and opinions. That was beautifully said. Thank you. We give Remeron to increase patient appetites. Really, Birdie, that's interesting, because remember, it was reported that she had lost a significant amount of weight. Even her friend had brought it up to her, or her coworkers rather. So I don't know what the first part of this was, but I do want to make sure that I say something about this. So about the Spider-Man scale out the window, I thought this was so interesting. Did anybody catch this? And I think it was today. I'm like, did I catch a clip from before? But I believe it was today. There were a few things. One, the defense says something about a hot mic moment, that they said shut her up when they were doing the autopsy, and she was crying. I thought that was like, I don't know if it was real, not real. Either way, if that was real, that would be horrible. The other thing is the Spider-Man thing out the window. This is my thing with that, you guys. Why? Okay, just hear me out real quick. There's no cameras. You have no neighbor cameras. Like, so there's no cameras. Nobody could see anything, right? If you really were faking this, which we also saw today, the prosecution is now walking back after the judge even said to them, I think it was yesterday or something in one of their hearings, like, oh, and he said something like, and this is paraphrasing, the prosecution's idea that this was a fake, you know, taking yourself out attempt, or and apparently the prosecution and the defense is also putting it out there about the fake attempt, and the you know, they keep saying about the superficial wounds and the this and that. So today, did anybody see the prosecution felt the need to put it on record that they're not saying that it wasn't a serious attempt, but their argument is that she didn't choose a method that pretty much succeeded in the job being done, like as far as taking her own life. It didn't work. I was like, wait, what? That is the most asinine thing I've ever heard. And I think they're probably getting, in my opinion, pushback, or somebody's watching social media. I don't know. But that was so asinine today. I thought it was crazy, and I couldn't wait to think what you guys had to say to that. What else was there? There were such a few things here. The business that, oh, that's the thing about the scaling down the side. You guys, there's no cameras. If you really wanted to fake that, why wouldn't you go outside and be like why take the chance of dying or becoming paralyzed from the neck down or the waist down? Like, you can't say like, oh, if I jump out, I'm just going to get paralyzed from the waist down. Like, do you guys see what I'm saying? So does that really make sense? Why wouldn't you just walk out back, lay down, and be like, and you know, ow. Ow, you see what I mean? Like, why she could have banged her head. Like, there were so many things. You could have dripped some blood out the window. Like, there were so many other ways to fake that fall. It's just hard for me to believe that she was faking or that she was trying to Spider-Man down the wall. My other thing is, this is another thing, and we've talked about this before on here. I told you guys about that documentary, The Bridge, where it's about the Golden Gate Bridge and how that's where most people complete suicide in our country every year from jumping. You know. And I told you about the one guy who winds up living, and he talks about how the minute he jumped, he regretted it and that it was such an impulsive thing. There are studies behind how many people regret after doing something impulsive like that right after, but I mean, it's too late in so many of the cases, if not most cases. So, but how many other people regret that right after? So I guess my thing is, what the hell was my point, you guys? I don't think she faked it, is my fucking point. To me, she had to get stitches in her wrist. I don't know. I don't want to go too much off on a tangent because I feel like I could. So I'm going to try to redirect myself. But that Spider-Man thing down the wall just seemed a little bit far-fetched. Not even a little bit, a lot of it far-fetched for me. And I just think that if I was on the jury, I wouldn't be buying that. My girlfriend's here. What's up, girl? Big truth. Some of these men should be charged with child neglect for leaving the kids with their mother when they... Oh, truth. Girl. You know how many men's in my Italian culture over here? No, not my dad. Like, used to love to tell the story that he never changed any of our diapers, ever. Not one. My sister, and this is how he told the story. One time, your mom had me babysit Carla. I like, did he just say babysit Carla? Like, that's your child. Like, mom had to run to... The one time, mom had me babysit Carla, and she dumped, and I was not changing it. So he walked her down to my Aunt Linda's house, because you know everybody in Philadelphia, not everybody, but a lot of us live, right? Walks her down to Aunt Linda, have Aunt Linda change her because he couldn't do it. So my thing is, and that would have been a disservice if somebody took my dad away because of, you know, not changing diapers or watching us, things like that. But how many things did he contribute to? So I guess my thing is, although I understand what you mean, and although I think it sounds great, right? And it probably would hold people more responsible, maybe get people to do more. In theory, it sounds great, but in reality, I could see that, you know, I'm sure you didn't mean it like specifically, but you know what I mean. All right, so let me move on or we'll be here forever. So this next part real quick, this episodic, this is the, you all right? So this is the problem in 1 minute. The psychiatrists observed, they asked, they reviewed the records, they sometimes contacted family or other clinicians, but internal experiences are partly known through patient reporting, which is why that's so important. If information is withheld, you guys, the diagnosis can be much harder to make, especially because there's such a lack of just blood tests, or you don't just go get an MRI. Like, it's not that easy. So withholding symptoms, which a lot of people do, are afraid. What could that mean for me? If I say I'm hearing voices, or if I say I'm psychotic, or if I say I'm having thoughts of harming my children, for example, well, that you know, will somebody take them from me? And then what does that do to me then? I already feel helpless, and I'm going to take my kids. Really, there's just so many things. Even with this doctor, with the medication, in my opinion, I feel like in the one, Lindsay finally was getting a little bit of relief from the Ativan, I think it was, or Valium. It was one of the benzos, and the Benadryl or whatever, and she immediately puts her on the taper off system. I was like, but she's just starting to feel better. Like, I know that there is a high risk for dependence, but don't you have to weigh that with like other, you know, negatives, consequences of that decision? You know, I've been anxious before. I couldn't imagine the minute, and it's like, why? So then we're talking about withholding. That's why I said that, because of withholding information. You can almost see why somebody might want to then withhold that they're feeling better or that this, that, or the other, right? Because who knows? Oh my God, Ivy. Wow, thank you, Ivy. Did I miss these? Ivy. Thank you, Queen. Oh my God. I appreciate you. Thank you. I do work really hard on these, you guys. And I was thinking about going to the trial. What do you guys think? I was thinking about going and driving there. It's 5 hours. It's not guaranteed to get in. I obviously would have to stay over somewhere. So there's like costs and stuff involved. And I would probably have to bribe one of my children to go with me. I wouldn't have to, but you know what I mean. It would be nice. So that's something I'm considering, but I really need to think about the logistics, the cost, the benefits versus, you know what I mean? There's just a lot. So if anybody has any, not advice, but like I don't know. If anybody has any 2 cents on it, let me know. Irony's here. What is up, Irony, from over there at the YouTube streets? That's where we met. How you doing? I'm so glad you're here. Thank you. But what do you guys think? Like, there is that risk of going there and then not getting in. I would go for 2 days, I think, because I'm not going to drive 10 hours around, you know what I mean, just to go for a few hours. But let me know what you guys think. But it is like a nerve-wracking decision. At one point, I was like, I'm doing this. And then I was like, oh, I don't know. You know what I mean? Okay, so getting back to this real quick, let's move to the next thing that I have clicked, or that I wanted to focus on, rather. I wrote here, the last thing that I didn't say before we move on, is that about the information withholding. The clip here that I just showed does not prove that Lindsay was intentionally hiding psychosis on January 9th. However, it does establish the limitations of the method that was used to measure it. So then 2 weeks before the death, the urgency in Lindsay's own words increases, which we're going to see next. So let me go to that next clip. Oh, we're getting to the end here. All right, right here. Oh, there we go.
She was still depressed. It was she was able to get out of bed and take care of her basics like hygiene and eating. Her concentration was fine, and she was doing what she needed to do to take care of her baby. Though she subjectively felt like the bonding was forced with the baby.
She told you that the bonding felt forced with the baby?
Yes.
Did you ask her if she had suicidal or homicidal ideation?
I did.
And what was her response?
No.
Did she show any of the signs or symptoms of psychosis on that day?
No, she did not.
Did you have a discussion about a Valium taper?
Yes.
And why did you have that discussion? Who brought that up?
That was because she really did not want to have to take a benzodiazepine medication every day for sleep. So we discussed how to come off of that medication safely.
And that, again, is that like taper off to take a little bit less each time?
Yes.
And did she agree with that plan?
Yes.
Was a decision made at that point on which, if any, antidepressant to take?
No, we had not made a decision. Oh, sorry. At this point, we did. We did go ahead and decide to try the amitriptyline.
And what is amitriptyline?
So it is a tricyclic antidepressant.
What does that mean?
It's an older antidepressant. It's been around for very many years. It helps treat insomnia and some pain, headache conditions as well.
And the dose that you prescribed, did you say it was 10 milligrams?
Yes.
Is that the lowest dose?
Yes.
And what's the highest dose?
It can get quite high, maybe 150.
And so again, you started her at the lowest dose. Why was it that throughout this time you're treating her and trying these different medications that you always start at the lowest dose with her?
That's standard practice because the medications, they have side effects, and the lower the dose, the more mild the side effects are, and it gives the patient time to acclimate to the medicine, and then you gradually increase it depending on how they're tolerating it.
And what was the plan going?
Okay, this probably isn't very, professional to say, but You know how I always talk about projection and poor insight? Could this have been poor insight on her part? Just saying.
Point. Well, like that. What was her mood and affect that day?
It was depressed. Mood was depressed. Affect was depressed and flat.
And at that point in time, where she's denying suicidal ideation, denying homicidal ideation, showing no signs of psychosis, were there any grounds for you or any reason for you to seek a Section 12?
No.
Your next appointment with her was January 23rd, 2023. Is that correct?
Yes.
Just so we know that Section 12 or whatever is involuntary commitment.
And again, all of these appointments were virtual appointments, correct?
Yes.
During this appointment, what was her mood and affect?
Mood was depressed. Affect was depressed and flat.
Did she tell you she had started the amitriptyline?
She did.
And did she tell you if there were any side effects to that?
It didn't appear that there were side effects.
What was the conversation or interaction with her that day on the 23rd?
So she said she was doing all right, a little more anxious, and the anxiety was described as the feeling of her heart racing. She had a decreased appetite as well. She was on only 2 milligrams of Valium at this point and feeling more anxious in the morning. Mood was the same, flat, anxious, no motivation, numb. She has to force herself to get out of bed and out of the house, but is able to do that. And she is sleeping okay.
And did you ask her if she had suicidal ideation or homicidal ideation on the 23rd?
Yes, I did.
What was her response?
No.
And did you notice any symptoms or signs of psychosis that day?
No.
Was there any difference in her rate of speech or speech pattern?
No.
Was there any difference in her ability to think or communicate in any way?
No.
Was there any change in her your evaluation of her judgment or insight?
No.
Did you still consider her insight poor at that point?
I did.
And why were you still considering her insight poor?
So I think there were just a couple of things that came up throughout our 14 visits that suggested that to me, like I explained earlier. But later on, it was it had to do with her over attribution, it seemed, to the medications about certain symptoms that she was feeling, meaning like how she felt about the Seroquel, how she felt that was making her depressed, when in reality, I think she was just depressed. So it was related to her thoughts about medications and how she was feeling.
So,
what's up, crop? How you doing? Welcome to our dysfunctional family, where we put the fun in dysfunction. That's the best I could put it, right? Oh, thank you, Harlot. And thank you, Irony. I appreciate you guys. It's good to see you. Thank you for being here. So we're just talking about this case. I don't know if how closely you're following the case, or if you're, I think you're following it, right? Eloise says, I think she was just depressed. What does that mean, just depressed? You know what I mean? Because for someone out there who's just depressed, that could be major depressive symptoms. I mean, that could be a lot. But we do see here that the day before the death, that there was depressed news reported, a flat affect. So affect is different than the way that she reports herself. So when they say to you, how do you feel? And you say, I feel good. If I report that you have a flat affect, that means that although you report feeling good, that I report that you don't necessarily look good to me, right? So, or that I'm not getting a facial expression, or I'm not getting from your expressions that you're, how you're feeling. So there's an incongruence in a lot of times. However, it was completely congruent here, where we see that she's feeling depressed, and that the doctor also reported that she had a depressed affect. So they matched up here. So she also reported the decreased appetite, numbness, which is a big one, but no motivation, forcing herself out of bed and out of the house. She says she's sleeping okay. Tufts says that Lindsay denies wanting to take her own life and denies wanting to take the lives of anyone else, and that she sees no psychosis, that speech and thought process remained appropriate for her. Then what's the question here? Is the insight still poor? That's my question. Tough says yes. This is the part I want to slow down for. So let's look at this real quick. Last time she said about it here, but she does touch on that poor insight one more time. I just want to, because she changes from, or not changes, it's just different. Let's hear what she has to say.
It had to do with her over attribution, it seemed, to the medications about certain symptoms that she was feeling, meaning like how she felt about the Seroquel, how she felt that was making her depressed, when in reality, I think she was just depressed. So it was related to her thoughts about medications and how she was feeling.
So would it be accurate to state that instead of accepting that she was depressed, she was placing the blame on the medication?
Sustained.
In your mental.
Okay, I have such a problem. So Tough says that the poor insight notion had to do later on with what she now calls over attributing it to the medications. I think, you guys, she should have listened to Lindsay more, in my opinion. And I'm going to show you why in a minute. So, for example, Lindsay believing that the Seroquel was making her more depressed, while Tough thought that Lindsay was depressed independent of the medication. So here's my candid reaction. This is where I think Tufts may have missed the significance of the information in front of her. Unknowingly, probably, and probably in good faith, but not because she had, poor insight equals psychosis. It doesn't. But because if my patient is increasingly desperate, as a complicated medication course, has severe sleep history, is telling me that the medications, as they change, that her, how she's feeling and how these things are worsening, and I simultaneously believe her insight into her own symptoms is poor, I want to ask how much confidence I can place in routine self-reporting, if no to every high-risk symptom. So if I don't trust your insight on those other things, where does her interpretation come here? Why does she trust certain things and not others? This is a question of uncertainty management, in my opinion, right? This isn't proof that Tufts bred a standard of care. It's not proof that the different decision would have prevented the deaths of these children either. And it's not proof that Lindsay was psychotic at that virtual visit. It is a question, though, about this uncertainty management. What additional collateral was available? What did Patrick observe? Were prior providers worried or communicating that they were worried? What was the complete medication timeline? What did dark thoughts mean? What was the nature of the insomnia? Insomnia with exhaustion, or a decrease for need for sleep with energy? Because like I explained earlier, when we talked about the DSM-5, that fact matters. And there have been any brief fluctuating psychotic experiences that maybe weren't present in that discussion. Those are all questions I would want later experts, and that I hope later experts are going to address. So let's listen to the plan that was made on January 23rd, a day before this horrible incident.
What was the plan going forward on that day?
So we were going to continue the same dose of the diazepam because she was feeling a bit more of the anxiety. So we said to slow down the taper, and we increased the amitriptyline to 20 milligrams, thinking that would also help with the sleep.
And at any point in time, did she tell you she was planning to kill herself?
No.
At any point in time on the 23rd, did she say she was planning to kill her children?
No, absolutely not.
At any point in time during your interaction with her in that session, was there anything about her affect or demeanor, her behavior that indicated to you that she was a danger to herself or others?
No.
Was there any reason, based on your evaluation of her in that session, that would give you grounds to file a Section 12 on her that day?
No.
Throughout your time treating Ms. Clancy, did you continue to recommend that she attend individual therapy?
Yes.
And why is that?
It's very important.
It is.
Okay, so Tufts slows down the diazepam taper because anxiety is increased and raises the amitriptyline to 20 milligrams, thinking that it may also help her sleep. But here she's telling her that the medications are making her worse, and I don't know that she's being listened to. She testifies that Lindsay never told her she had planned to take her own life, the life of the children. So there is a point I want to make here, because hindsight can make clinicians look clairvoyant only after a disaster happens. A psychiatrist can't involuntarily hospitalize every depressed patient who denies wanting to take their life or the life of someone else, and who presents with organized thought, but that she feels lacks insight. The legal and clinical threshold here matters. So my critique is a little bit narrower. Was the longitudinal pattern more concerning than the point in time that the appearance suggests? So should we be looking at patterns here, like I always tend to point out? That's what Tufts, this is my biggest focus with her. She gives us both sides at once. The point in time that the examination looked organized, and the longitudinal record of desperation over time, sleep disruption, multiple treatment attempts, and persistent poor insight. I think that's going to come back to bite her, in my opinion. We still have to ask the hardest question. What psychosis can psychosis exist in someone who is capable of conversation, planning, and normal looking behavior? And I think we're going to find that the answer to that is yes. But before we get to that, I want to show you guys, let me stop my share here. I'm going to share again. So, okay, so Dr. Joseph, I think that's just the name, Dr. Joseph. Oh, hold on. Dr. Joseph. Hold on, let's see if it comes up. If not, it's in my, oh no, I got it. Okay, so we're going to listen to what Dr. Joseph has to say. Let me just share this with you. And he is a board certified psychiatrist, but he's going to tell us that himself. Wait, what? It's fine. I'm going to share my screen with you guys, and we're going to look at Dr. Joseph, so what he has to say. All right, here we go. If everybody could go over there after, open up a second screen or something, go subscribe. But this is Side Effects with Dr. Joseph, okay? And, oh, well, he's got 260,000 subscribers, so you guys probably already know who he is. But let's listen to what he has to say, because I think what he says is so important. All right, here we go. And let me just turn that off for 1 sec.
2023. Lindsay Clancy from his
home in January 2023. Clancy's lawyer is mounting what in essence is an insanity defense.
and an involuntary intoxication defense.
It's expected he'll try to convince a jury that Clancy was not criminally responsible, that she was over-medicated in treatment for postpartum psychosis.
From a human nature standpoint, I wouldn't want anyone to have to be.
I'm going to try and skip forward a second, because you guys know the gist of it.
Intoxications, essentially a defense that the drug made you do it. You are always going to be looking for alternative explanations for the behavior. Now, in something like murder, what are the alternative explanations? Well, the person had a past history of aggressive behavior. Maybe they were abusive. Maybe they had problems with alcohol. Maybe they had severe unstable mental illness. All of those things could play into it. Now, what's interesting about Lindsay Clancy is she had none of these things. She had no prior history of severe mental illness. She had a few episodes of mood instability following the birth of her first 2 children. However, aside from that, she was a doting and loving mother of 3. She was a wife. She was a nurse, and she never had any of these problems. She didn't even take psychiatric medications previously. So essentially, the prosecution, who's going to try and pin murder on her, is trying to say that she was secretly a psychopath or something like that she was harboring these feelings and they were premeditated, and it just came out of the blue and no one expected that. I think that's actually a pretty weak case. And what I want to do with you now is actually go through the argument her lawyers are putting forward for her malpractice case. So let's jump into it. Okay, so this was filed at the start of this year. Okay, so we're going to bring here. So after the birth of her 3rd child, she went into an episode of postpartum anxiety and depression. Recognizing that something was wrong, she went and reached out to her doctor, Dr. Jennifer Tufts online, who put her on Zoloft. And then Lindsay experienced a severe adverse reaction to this. She did not sleep for 48 hours, had racing thoughts, worsening anxiety, and felt awful. This was a dramatic departure from previous sleep patterns and an obvious warning sign of medication-induced activation consistent with bipolar disorder. So something you're going to see about this case is that her current experts on her side are actually saying that she had bipolar disorder as evidenced by some mood instability that she had during the postpartum period of her two earlier children. You know, and this.
So before we move on, I do want to say, so I had a little bit of a moment today at the same time, because what I thought was, I was like, wait a minute. She didn't have, because they kept saying, like, did she have signs of borderline? I'm sorry, of bipolar disorder, so on and so forth. And they kept saying no, all the doctors. I don't know if it's because there's that civil lawsuit or if that had anything to do with it. But this doctor is suggesting that it might, you know, it could have been that, but it might not have been that, that there's a whole other thing that are we not even focusing on, which would be that toxic reaction that very small few percentage of the population gets.
Can make sense because the case that they're trying to make is that she got put on these SSRI medications and they essentially triggered mania and psychosis. And if we come over here to the label of an SSRI medication, Zoloft, what we can see is this is already a recognized risk, that the drugs can cause activation of mania and hypomania, and that you should screen patients for any personal or family history of bipolar disorder, mania, or hypomania, so you're aware of this and you can quickly either avoid the medication or stop the medication if it's worse. Now, her defense experts are essentially making the case that that didn't happen. However, there are quite a few other things that can cause these problems, and I see them in my practice. These SSRI medications can be quite neurotoxic to people. It's not common, it's fairly rare. But quite frequently, I have people come in and they're exposed to an SSRI for a few days, and it causes a whole host of problems. They can have visual problems. Sometimes they get ringing in their ears. Sometimes they can have confusion and mood instability. It's almost just like a neurotoxic reaction that hits the brain. Now, a lot of doctors look at this as something called serotonin syndrome, but generally that's not diagnosed unless someone has a lot of like blood pressure problems and sweating and frank confusion. And so it's often missed. But you actually see these minor toxic reactions fairly commonly. And after you get one of them, you can have this fallout effect where for multiple months afterwards, they have nervous system instability, they respond poorly to medications, drugs make them worse, and essentially they can have mood instability and psychosis as well. And that's...
I mean, you guys, right there, he's real, Travis. This is a real person. It sounds like the video sounds might be coming through your microphone. Oh, was it good before this, Harlot? Of course. It was fine until then. Well, not for nothing. We got almost 2 hours into it before things started to get messed up. So let's just be happy about that. But I will up the sound because usually I can figure out what it is. And I think I'm getting better and good because unfortunately it happens to us a little bit more than I would like it to. So while we do that, let's talk real quick about what's happening here. So he's suggesting that could this be that she was experiencing toxicity? We do know that for some of you, even in our chat, that have said that you have had, you know, horrible effects as well. Could this be something where it's like that very small percentage of the population, but enough that this is what's happening? And I think that we need to be careful of that. So let me see, you guys. So over here, as my sound, I don't know, hopefully I just figured it out. But if I didn't, let me know. We'll figure something out. All right, let's see, because I really want you guys to hear this, Dr. Josephs. I'm trying to think, does anybody remember what I did? I have to like write down the things that I've done before to make sure that I get them here, but let's see. Could it be, let's see.
Something that I'm not seeing in this document, but it's something that I have seen in a lot of my patients, which I know can happen. And just so you know that this isn't just me, you know, we're back over here at the drug label now, looking at the adverse reactions that occurred in less than 2% of patients that were treated.
That's the important part here, guys. This is less than 2% of the people that use this medication. So for most people, they're not going to have these effects. But for a few, you know, they might. And he has it highlighted here. Other infrequent adverse reactions not described elsewhere in the prescribing information occurring in incidents of less than 2% of patients treated with Zoloft, which means, right? So if they're saying this, that means that during the clinical trials, that they did report this. So it's not that this could happen. They're saying that what they found is when they did their, when they did the studies, that was exactly what they found. Hey, Joanne, how are you? Let's see. Let's keep going because I do want you guys to hear what he has to say.
With Zoloft. And if you come down here to nervous system and psychiatric disorders, they observed ataxia, so that's unsteadiness walking, coma, convulsions, decreased alertness, lethargy, syncope. For psychiatric disorders, there's aggression, bruxism, which is teeth grinding, infusional state, euphoric mood, and hallucinations. And so these are all things that the manufacturer found during the clinical trials. And so the drug companies are also seeing the same thing. Now, jumping back over here, another thing that I want to show you is that when her dose went from 25 to 50, that made things worse. Now, in drug safety, we call that a dose response reaction. And so if you're feeling bad on a drug and you go up on the dose and it makes you worse, that's a pretty good sign that the drug is responsible for making you worse. And so I just want you to remember that because...
So you guys, this is a board certified psychiatrist. He's very much real. You guys know that crime show, Law Confidential, is it? With, what's his name? It's on the tip of my tongue. It'll come to me. It's like Law Confidential. And he had him on earlier. I couldn't believe it. I was like, oh my God, I found this guy yesterday and I've been like trying to listen to some of his stuff. And I saw that they had him on today asking him questions about this as well. So he is very much real. And I think that he's making a very important point here that we need to consider.
What happens after this is very interesting. She goes back to the doctor, and the doctor essentially discontinues the Zoloft and prescribes a cocktail of medications for sleep. However, even after stopping the Zoloft and starting these other medications, she still has profound insomnia and distressing cardiac palpitations. Again, for me, this seems to be a sign that she had a toxic reaction initially to the Zoloft, and now it's causing some global problems. That's why you're having heart palpitations, insomnia. I know it's not in here, but she may have had some visual problems, some ringing in her ears, different things like that, all signs of a neurotoxicity. She ends up going back to the hospital and the doctor prescribes her trazodone for sleep, but that's not helpful. Again, once someone's had a neurotoxic reaction, they typically do not respond well to additional medications. Out of desperation, her mom, who's a nurse at a different local hospital, the South Shore Hospital, she contacts their perinatal behavioral health program, asking for additional help. And that's where she meets nurse practitioner Paul, who prescribes Prozac. Now, here's why this doesn't make any sense. If you had done a proper history, you would say, okay, well, there's this dose-response reaction to the Zoloft that made her worse. I'm probably going to avoid drugs from a similar class. Remember, Zoloft and Prozac, they're in the same class of medications, SSRI medications. And so if someone's having a neurotoxic reaction to an SSRI, you're not going to expose them to another one because that can further irritate the nervous system and make...
So that was one of my problems with Dr. Tops, you guys, was that instead, why would you switch to a different, it's like going from penicillin to amoxicillin. It's like they're in the exact same class. So if you're having a horrible reaction to the one, maybe switching to a different medication in the same class isn't going to be effective. So, but again, a lot of this is just hindsight. And again, I am not a psychiatrist, but I thought a lot of these things, and I think that he's making great points.
Her worse. And so here's what they find happens afterwards. After merely 4 days on Prozac, Lindsay reports that the medications intensify her insomnia. She immediately informs her providers, and the Prozac is discontinued. This was the second antidepressant that caused activation and worsening insomnia, a critical red flag for bipolar disorder the providers failed to recognize. Yes, bipolar disorder, but also drug toxicity. Afterwards, Nurse Paul goes on to prescribe, again, a cocktail of sleeping medications, so Ambien, potent sleeping medication, Remeron, potent sleeping medication, Clonopin, potent sleeping medication, and anti-anxiety med. Now, in most cases, you would expect this to work. You would expect it to put someone down. But as I mentioned before, if you've had a neurotoxic reaction and you've destabilized your nervous system, people don't respond to drugs in typical ways. And so let's see what happens. Well, after taking these drugs, Lindsay experienced dissociation, perceiving the world around her as unreal, distorted, and distant. She was unable to determine what was real. She became disoriented, forgetful, confused, and disconnected from her own body. She was unable to drive and unable to be left alone. This is not a typical reaction to these drugs at all. This is a sign that someone is responding extremely poorly to medications. And that should be a clue to anyone looking after her that, hey, more drugs is likely not the answer to this person. This nervous system is not responding well to these medications. So after getting put on these medications, she ends up following up with another nurse practitioner about 3 days later who diagnoses her with bipolar and prescribes Seroquel. Now, most people would expect, hey, you've got the diagnosis right. Bipolar disorder, and Seroquel is FDA approved for bipolar disorder, along with a lot of other antipsychotics. Okay, we've got the right drug now. Shouldn't this work? However, look at what happens. After starting Seroquel, Lindsay's condition took a dramatic turn for the worse. She developed suicidal ideation and began experiencing what she describes as intrusive thoughts, which were auditory hallucinations. The voices said, "I will not be the same. I want to die." She communicated her escalating internal turmoil to her husband, parents, and providers. She described her emotional state as emotionless and like a zombie, attributing this profound blunting to Seroquel. On top of this, she ends up losing 15 pounds, has no appetite, and is experiencing panic attacks and confusion, and has a lack of attention over several days. She becomes so frightened by the hallucinations that she calls the suicide hotline seeking help, but they don't hospitalize her because she doesn't have a plan on how she's going to kill herself. She does it again with Aspire Crisis Support. Again, they don't hospitalize her because she doesn't have a suicidal plan. Her husband then follows up with her and her nurse practitioner. Her husband is Patrick. And here's what he says to her. Lindsay is 10,000 times worse since she's taken this medication, and asked if they could get Lindsay off the medication and start from scratch to see what's going on. He asked if there could be some mistake, like using the wrong medications. And Nurse Gilletta acknowledges it's possible. But despite this, she continues to increase the Seroquel dosage towards 400 milligrams a day. Now, this
Okay, I think that, sorry, it's going to take me an extra second to put my mic back on because I have to like mute it in 4 places, but I'll do what I have to do. You guys said that it sounded better. But you guys, yes, Harlot, in truth, rather, she's telling everyone here too, right? So, and then Patrick goes and we see, so what does Patrick do? He tells them that she's 10,000 times worse since she's been on the medicine. He even said, could there be a mistake? Like, so it's not just her crying out for help. Now Patrick's crying out for help. And what do? Instead of saying that, yes, that's possible, they continue to increase the Seroquel to 400 milligrams a day. What? I mean, oh, look, YouTube, look who's here. Thirsty's in the house. All right, let's keep going and listen. It's going to take me a second to mute both things, so just give the sec while I hit mute.
possible, but despite this, she continues to increase the Seroquel dosage towards 400 milligrams a day. Now, this is just absolutely heartbreaking what is going on here, because the intuition of the husband and the intuition of the patient is correct, that these drugs are actually hurting her. And she has this initial bad reaction to the Zoloft. She's destabilized. And it's almost like every time she gets exposed to another one of these drugs, because she's had this toxic reaction, they're making it worse and worse and worse. I see this a lot in patients with protracted withdrawal injuries and bind. These are different adverse psychiatric drug reactions which cause essentially nervous system damage. And after they happen, every time you take another medication, it causes a quote unquote kindling reaction, which is essentially further damage to the nervous system, because once you destabilize the nervous system, additional drugs often make it worse. And so this nurse doesn't pick up on it. They have this kind of this sense that, hey, better be safe than sorry. Let's just use more medications. And they end up increasing the amount of the drug. Patrick then calls the nurse's office to report that Lindsay had a devastating week. It was the worst day for Lindsay. She had horrible thoughts all day, auditory hallucinations every day, felt debilitated, not interested in anything, can't get out of bed. The hallucinations are now loud and continued all day, saying, I will never be the same. I'll never be me again. You are damaged. You'll never be the same. The only option is to die. So this is someone who is having a severe toxic reaction to medications at this point, and she's essentially being tortured. She goes on to tell her husband, I have thoughts of harming the kids. She also told her mother about these thoughts because she was in a psychotic state. She began to have paranoid delusions that people could hear her thoughts, and then she would be locked up in a hospital and have her children taken away.
You guys, that's my biggest thing here, you guys. The whole fear that, what did I say earlier? I said if I had to put myself in that position, all I could think is what's going to happen if I tell the truth. If I tell them that this is how I'm feeling, are they going to take my kids away? Am I not going to be able to see my kids? So imagine how hopeless one must feel, or how desperate one must feel, that she tells Patrick and her mom that she's having thoughts of hurting herself and her kids. So then I see, so wait, what was it? About, as far, Birdie, I hear a lot of people say that, as far as leaving the children alone with her, my only fear with that is, and again, I guess, you have to look at this both ways, because you can't just say, oh, you're just going to chance it if you know that there's that horrible risk. But then on the other hand, this happens, this is so rare, that the fear, I would think, and this is, I'm just speculating, but I would speculate that in the psychological community, that the fear would be that women wouldn't come out with their symptoms, because that would make their fear even stronger if somebody does take the children from them. So I think that we need to remember that as well. That's like one of the reasons people don't speak up. So it's almost like a dysfunctional feedback loop, if you will. And it's a shame. We have to do better all the way around, because, you know, for the kids, for the people suffering, everyone. Hey, Jenny, how you doing? How you doing? All right, let's keep going.
Now, this can be like a real stretch for some people, that it's like, okay, yes, you could be confused, you can have these adverse reactions, but at what point, like, does it start to become like homicidal? And I've followed a lot of these cases. The one that comes to mind was, I think it was a California woman who was smoking cannabis. And sometimes this can cause these delirious type reactions. But I've also seen this in my own practice. You actually feel like you descend into hell. When you're in a state where your brain is dysfunctional and you have severe anxiety, you're constantly in a negative mood state, you haven't been able to sleep, you sometimes feel possessed, almost like possessed by a demon. And you hear these voices, and you start to hear voices that are saying, you know, the only way that you're going to get out of this is if you kill yourself or if you kill other people. And you can be completely consumed and taken over by these delusional, delirious, fever dream type thoughts. And so that's what happens. Shortly after this, Lindsay ends up being hospitalized at McLean Hospital. Now, this is Harvard's hospital. This is the best psychiatric hospital in the United States, supposedly. And the doctors there advised Lindsay to stop the Seroquel and the benzodiazepines, and they prescribed trazodone for sleep. And a few days later, Lindsay asks if she can go home because it's her daughter's birthday, and they allow her to go home. And potentially she may have gotten better at this point if she wasn't started on additional medications. However, she ends up seeing Dr. Goodhart from McLean, who speaks to her for only 10 minutes and offers her more antidepressants. They suggest amitriptyline to her other doctor, Dr. Tufts, who ultimately prescribes the amitriptyline to her. Now, again, this is crazy. You know, this person has had 2 bad reactions to antidepressants that are clear, you know, the Zoloft, and then also the Prozac, and then she was also on the Seroquel. And now they put her on another antidepressant, amitriptyline. And this really sets the stage for what happens next. Because after she starts the amitriptyline at 10 milligrams a day, she still doesn't get any better. And then Dr. Tufts, psychiatrist, increase.
So you guys, this is where we're going to see. Remember when I said earlier in the live, this was my problem, right? Is that is she not listening? She says she has poor insight, and I had such a problem with that. Oh my God, Thor, are you serious? My dog is just too much here. But we're going to see here that she, come on, Thor. We'll just listen, and I'll put this part when we'll listen why Thor does it.
This is the amitriptyline to 20 milligrams per day, and that makes her worse. And this is the day before she ends up killing her children. And so this is kind of graphic now, but I want to read through this. And, you know, I advise you turn it off if you don't want to hear this, but this is what happens on July 24th. Lindsay wakes up severely depressed with suicidal thoughts. She gives her children breakfast. She takes her daughter to the pediatrician because she complained of a stomach ache. She goes home. She goes to the backyard with the children. They build a snowman, and they send a picture to Patrick and her mother. She begins to experience suicidal hallucinations all day nonstop. Later in the afternoon, the voices begin saying, "You should harm the children." Lindsay thinks about dinner and realizes that she hasn't prepared anything. And so she asks her husband about takeout. Now, this is like what the prosecution says. This was a premeditated thing because she told her husband to get out of the house and get takeout. I think this is like such a big stretch, you know, in the context of everything going on, to make this case that she'd been secretly thinking about this for a long time. It goes on to say this: as soon as Patrick left to pick up the food, there was a loud, demanding, repetitious voice. This is your last chance. Kill the children so you can kill yourself. This is your last chance. You have to kill the kids so you can kill yourself. Lindsay felt a force overcome her. Lindsay experienced command auditory hallucinations. A demanding, powerful male voice explicitly ordered her. She felt an overwhelming, irresistible compulsion to comply, entering a dissociative, dreamlike state where her physical actions felt utterly disconnected from her conscious volition. She perceived her body was just acting, and she was merely watching herself do it. She reported she had no choice but to follow these compelling directions. She described, "I lost all control. My body started acting without control on my part. I was just following commands." She then proceeded to strangle each of her children, uttering, "Go to God, baby." Following these acts, she undertook a severe suicide attempt, ingesting a substantial quantity of various medications, self-inflicting lacerations to her wrist and neck, and jumping from a second-floor window approximately 20 feet to the ground below. For our non-US listeners, that's about 6 meters. That is a massive drop. Lindsay suffers catastrophic injuries, including a thoracic spinal cord injury resulting in permanent paralysis below the sternum. That's why she was in the wheelchair at the start of this video. And she suffers multiple closed fractures of her cervical and thoracic vertebrae.
Sorry, extra steps. But yes, thank you for sharing that cup. I didn't want to like highlight it, just you know. Oh my God, hold on. Dogs, it's not.
Lindsay consistently maintains her actions were compelled by a hallucinatory voice, not a conscious decision, and expresses profound and enduring love for her children. I don't know anyone that could hear this case and not just feel utterly enraged by what happened to her. I mean, the senseless loss of life of these 3 children for no reason when it was so clear that she was responding poorly to these medications. I don't know when the psychiatric establishment will wake up and realize that you can't just keep on throwing drugs at problems. Sometimes the drugs make people worse. Sometimes you have to take them off them. You have to monitor them. You have to keep them safe. You have to admit that, hey, these drugs can make people toxic, and now we just have to wait for you to recover. But they never do any of that. There's this sense that more is always better. And to me, we're going to see what happens in about a week's time when this case unfolds. It'll probably be wrapped up within 2 months. But to me, right now, the most telling thing is that her husband, Patrick, is standing by her during this. Could you imagine being the husband? You've definitely had those thoughts, was this premeditated? But for him, the person who lived with her every single day and watched her go through this, if he is looking at her and saying, this was due to the drugs, this is not my wife, to me, that speaks volumes. I'm going to be watching this case with a lot of interest because psychiatric drugs are certainly going to be on trial. And I think the cautionary tale in this is that, hey, more drugs is not always better. And so if you feel that you're getting worse on these medications, listen to your intuition, talk to your doctor, start thinking about coming off. And if you're really struggling about coming off, that's actually something we do. And so you can check the link.
Okay, you guys. So this is Dr. Josephs again, and hopefully everybody goes over. Birdie says you love this doctor. I know you meant me and not the restricted. I do too. And I've never seen him before, so I just found him in all of this, so I'm glad I found him. I think he's great. Travis says that Texas is trying to shut down oral medication. Oh, for like Plan B. That's interesting. That's a whole different thing, isn't it? But again, I think that this whole topic is really important, and I think that it's important that we looked at that. So hold on, let me stop that share real quick. And let me see if I had any of these slides. So postpartum psychosis, you guys, is rare, it's severe, and it's an emergency. Again, it's only 1 to 2 per 1,000 births. And possible features or things that you should look out for is insomnia, excessive energy or agitation, paranoia, suspiciousness, hallucinations, and other psychotic symptoms. So severe mood symptoms are common, and the condition is strongly linked to bipolar spectrum illness, but it doesn't mean that that is what's linked in this case. As a matter of fact, I don't know, we don't know exactly what the diagnosis is exactly yet, other than the postpartum psychosis, if there is one. So they're selling Plan B at the gas station here. Where are you at, Crop? Crop, I'm in Philly, and it's pretty, yeah. Crop, I'm in Philly, and you could go buy it at CVS. I'm positive. Joanne, thank you, Queen. Thank you so much. Yeah, you guys. So Plan B is different. Oh, it's different case. So Are You Barbie asks, is the DSM-6 really coming out in a few months? And that's what the defense said. I have to be honest with you. I've been doing so much, work on this that I hadn't had the opportunity to look it up. But I will look that up. I'm like, if there is, I'm getting myself on. Thank you, Harlot, you queen. Thank you so much. I appreciate you. True says Plan B works if you take it within 3 days of having unprotected sex. And that's what would make it, right? Oh, I guess, right. So that would make it different than the other one. Oh my God, you guys, I got happy poop. I love it. Thank you, Harlot. Thank you, Casey. It took a second. You're in Indiana. Oh, nice. I'm over here in Philly. So you guys that are, that weren't on earlier, I was thinking about going to the trial for like 2 days, but let me know what you guys think. I'm curious. I'm curious. Thank you guys again. I do appreciate you. So I have over here real quick in my notes that I'm sharing with you that timing is a real clinical tension in this case. So we have a classic pattern, which is days to weeks, and that's what I think a lot of people are looking at. So most psychotic episodes begin early after delivery. However, in Lindsay's timeline, this occurs 8 months. Her youngest child was about 8 months old in January of 2023. So the unusual timing does not settle the diagnosis, in my opinion, but it must be explained, not skipped. And I think one of the things that, can help explain this is, I don't know if many of you remember, most of you probably remember the Andrea Yates case. In that case, she was found guilty at first, but then her prosecution was overturned because, that guy that was on the stand said that she got this from like a CSI episode and none of that was true, so they overturned it. In the second trial, she was found guilty, but by reason of insanity. So she still stays in a hospital to this day. And Rusty, her husband, keeps in touch, well, her ex-husband, still keeps in touch with her. And he says that she was absolutely psychotic, and that didn't occur until 6 months after the baby was born. So maybe these, maybe the time duration, especially because it doesn't have its own category within the Diagnostic and Statistical Manual yet. Hopefully it will in the next, it wouldn't be a revision, it would be the next edition. So hopefully it does in the next edition. But that's some of the things that are going to need to be considered, like the time duration. When do these things start? What constitutes, would you have a psychotic episode right away? Could it be worsening depression over time? Could this also be, you guys, what if? And this is just coming to my brain as I'm saying it, so please keep that in mind. But what if they prove that this isn't postpartum psychosis because of the current criteria, and that it doesn't fit the current criteria? Could you then take on the defense that it was drug toxicity? I think you can. And this is my thing. I think it's probably a mixture of both. I think probably both things happened. I think she probably had the postpartum depression with these medication toxicity type things, and mixed together created a recipe for disaster, unfortunately. And the truth is that for most people, you guys, these things like this, for most people, they will get on these medicines, and these medications will save them from, their most horrible thoughts, and they will get better. So for most people, please continue to go to the doctor and please tell them what your symptoms are. Hopefully a case like this will, if anything, at least bring more awareness to what it is that we need to be looking out for. And again, I know that some of you still feel that this was intentional. My thing is that in order for this to be intentional, think about it, you guys. And real quick, thank you to Joanne. I appreciate you. That means so much to me. You're so generous. And thank you also to Butterflies. Thank you so much. I appreciate you guys. And then we have Jeannie. Thank you. Wow, you guys, I appreciate you. Thank you. I couldn't do this without all of your love and support here. So please hit like and subscribe if you're not already. Of course, you said she was definitely over-medicated, in my opinion, and then was going off and on them. Are you, Barbie? I'm kind of glad that you shared that, and that you also shared that it took you at least 3 weeks to know if it worked. And then trying something else in small amounts, tapering on and off those meds can mess you up. Absolutely, right? So you could absolutely make that argument. You could also say, and I would say this, it is absolutely common for people to, especially, now we know she did try medication when she was in nursing school. But other than that brief time, medication wasn't something that she You know, it wasn't something that she had done before, so she was hesitant to go on medication. I think that's true of many people. And then once on the medication, she would have second thoughts and get all, you know, and then she switch it in between medicines because they're not working. I will tell people that when you talk about something like a benzo, like a Xanax, Valium, Klonopin, Ativan, these are benzos, and benzodiazepines work quickly. So you take one, and within, you know, 30 minutes or so, like you feel it. So you feel it on the first dose. It is much different than that with antidepressants. So an SSRI, selective serotonin reuptake inhibitor, I think I gave you the analogy before, like the gas tanks and the fill in the gas tanks. And with the SSRI, if you guys remember that analogy, it's like putting that gas cap on so it can't get sucked back into the gas tank. And, you know, anyway, the point being is that, I don't know, what the fuck was my point, you guys? I just got distracted because I seen Joanne. My medicine clearly is no longer working. Prep. Just so you know, I have severe ADHD and I'm usually medicated, but when it gets this late, you can't be medicated 24 hours a day when you have ADHD. I'm only medicated when I'm working, I should say that. Someone said benzo. Sorry. So yeah, benzo. So she was on multiple benzos, you guys. And she was reporting finally that the benzo was helping. And the day that she's reporting to the doctor that it's helping, the doctor sets up a tapering off plan. I can't imagine something making her feel more anxious in that moment. She was feeling desperate, and she finally started to get relief. And now you're going to taper me off because you're afraid that I'm going to get addicted to them? Like, what? So I don't know. I felt her anxiety today, and I don't know if that was me, you know, identifying with something that I've been through in the past. Maybe, I'm not sure, but we'll see. Oh, you guys said just took mine. That's so funny. That's funny. So Dr. Goodhart, you guys, that was the first doctor that we saw. This was the slide or the notes that I had for her that I made. I could put these slides up or whatever if anybody's interested. If you're not, it's really, you know, it's either way. But if somebody ever wants these, let me know. And I share all of my stuff. I could share it on my Discord, or you can email me, or we'll figure it out. But let me know, and I can always post them. I then give you a little bit about Tufts, which we also saw. This was the one that about the where she said she lacked insight. I did not like that. The poor insight matters. Look, I made an entire slide here. So I also think it was important. One of the most important things that, you know, not important, one of the most striking things, I guess you would say, is the fact that when she says that she has poor insight but excellent judgment, that was so big. That popped out to me like symptomology. And I'm like, why didn't that, you know, pop out a little bit more to her? And maybe it did. I don't think it did, but maybe it did. Who knows? Oh, thank you. Yes. Thank you. Bucket Pinata was the lucky recipient. Thank you so very much, Joanne. I appreciate you. You know what, you guys, hang in there a few more minutes and I will donate, or whatever you call it. I will gift, I said donate. I will gift 5 Mind Behind True Crime memberships. But for right now, thank you, Joanne. Joanne has gifted a Mind Behind True Crime membership, which I love when people do this, because I love, it's like the lottery and you get to see the scratch off, like who gets it. So our lucky newest addition is Bucket Pinata. So Bucket Pinata says, thank you so very much. And I agree, thank you so very much. That was so very kind of you. I love when people, I get so excited when I get a gifted membership. I'm like, well, part of the family, but I almost forgot. Welcome to the family where we put the fun in dysfunction. We can't forget to say that. You need to get a shirt made with that shit on it. So severe anxiety and reluctance to medicate was the reason, real quick, just to go over our notes, that Dr. Tuff said that she had poor insight. Later, Lindsay She said that Lindsay over-attributed her symptoms as coming from the medication. Tufts believed depression explained more than that it was coming from the medication. She just thought she was just clinically depressed at that point. Over here, this was Tufts' record as a trajectory, not as one visit. I think this is going to be important when it comes to the defense. So you see here in September, so she sees her in September, October, November, December, January, and then there's another time in January. There were a few times in between, but I was just, I didn't list all of them. I was just giving us a visual of the progression of symptoms. It starts out with anxiety and poor insight. It then goes into her taking Zoloft for worse sleep. She has GI symptoms, fog, and anxiety. Then by December, we add multiple trials of medications, reports worsening sleep, intrusive fear. That was a big one. The intrusive fear to me is probably the start of her psychosis, in my opinion. Then by January 16th, we have desperate for something to work. Think about that. Just the words desperate. She's desperate for something to work. And then by January 23rd, the day before, she reports depressed, flat, anxious, poor, her insight remains poor. So, I hated that insight thing today. Then January 23rd, the last Tufts visit before the deaths. So these were the things that were reported. The plan was to slow down. So wait, you guys, this is what I'm talking about. Ready? So she's depressed. Her affect is flagged, meaning she has no facial expression to Dr. Tufts. So Dr. Tufts isn't reporting that she looks sad or happy. She just has a flat affect. She can't really tell. So she reports more anxiousness. So if she's reporting more anxiousness, why would you slow the diazepam, which is the benzo? And then increase the amitriptyline. Isn't that like Benadryl? Somebody let me know. Travis says intent isn't the issue. It's criminal intent. What? Is the mental condition prevents the intent raising to the level of criminal intent. So is the material condition prevents the intent raising to the level of criminal intent, which is why I think she's going to get off, in my opinion. Barbie says, I hope they got her on a benzo for this trial. You know what, Barbie? I think that she's probably medicated. I don't know what it is she might be taking. But yeah, I don't know. Barbara's here. Barbara, how the frig are you doing? I miss you, kid. I heard things are going on with your son's trial. I said trial. See, I'm projecting. Maybe we'll put that out in the universe. Let's get that out in the universe that someday there's a trial for the person that took your son's life. But I heard that there's traction in the case a little bit, and that DT went out there and stuff. So that's great. We're going to be obviously following that. Casey says, I would think she would have to be mitigated right now. I think you meant medicated. That's what you meant, medicated. Oh, thank you, Harlot. I appreciate you for my floating heart. You are amazing. Okay, this next slide that I have, I don't know why, they're just notes really. Medication list is not a toxicology result. So I have more things that we could have done, but I'm like, this slide's getting a little bit long. So I skipped a little part there. And then we had Dr. Joseph Whitdowering. He is a psychiatrist. He's the former FDA medical officer. So the one that Travis asked if he was AI or from Australia. Apparently he lives on the West Coast now, someone said. And he is a former FDA medical officer. His public commentary raises medication, polypharmacy, involuntary intoxication hypothesis. So let's not turn that into proven serotonin toxicity or toxic antidepressant blood levels. They're different claims. But I am curious to see what they're going to have to say when the defense puts on their case. Thank you, Joanne. I so appreciate you. That was so nice. In Massachusetts, the insanity defense is officially termed lack of criminal responsibility under District Court Model Criminal Jury Instruction 9.200. Have Dr. V Google that and pull it up. Okay. So what do I look up? Criminal. Shut up, Birdie. Bert Travis, look up. Shut the frig up. You guys. Birdie, thank you. Oh my God, you guys, look. Birdie gifted 5 memberships, and our lucky new dysfunctional family members, thank you, Birdie, is Travis. Travis, you finally got one. Krupp got one. Yes. Jingles got one. Edith and Mrs. Mac. Wow. Oh my God, I'm so excited. Look, Travis is excited too. Welcome to the Minds Behind True Crime, where we put the fun in dysfunctional. I'm so excited. Thank you so much. That was so cool. And then I'm going to do it in a few minutes. That was awesome. Travis, I'm going to pull that up for our next live, the statute, just because I don't want to get sidetracked, and I know me, I'll wind up getting sidetracked. So I'll make sure that I have that up for next one. I do want to make sure that Cora, Dawson, and Callan always remain the center of what we look at as well. Wow, you guys, I'm so excited. All right, now we're going to go to my channel, and I'm going to get 5 memberships. So hold on, let me pull my thing up. I'm so excited. Yes, welcome, Krupp. I'm so excited, you guys. Krupp's in the house. Everyone go subscribe and like to all our, peeps in here that have their own channels and stuff. I am so supportive. Yes, Krupp, isn't that so exciting? Welcome. Oh, Joanne, thank you. Joanne just sent party hat for 20 jewels. Thank you so much. I appreciate you. All right, now I'm pulling up my thing. Let me go to gift you guys memberships. Let's see who gets them. So excited. I get excited over the stupidest things. You could tell, like when you made it. So excited. We made it to your 40s. You can so tell you get excited over the dark things. Out there and like and subscribe, please. I would so appreciate it. So let's see, of the people watching, let's see. Oh, I should put this up here so you guys can see it. Not that it matters because you're going to see it anyway, but let me show you. All right, you guys, who's going to get it? Let's see. All right, so I have to go over here. Membership gifting. Make sure you have your things on. All right, ready? Let's see who got them. Okay, let's see who. All right, we have TN, Chris V, L Cool Day, cool friggin' name. This normal Idaho mom and Dreamcatcher. Welcome to the Minds Behind True Crime with Dr. Vona, where we put the fun in dysfunctional. Welcome to our fantastic little family over here. So there you go, you guys. Welcome, welcome. So we have a lot of new members this show, and I hope everybody enjoyed what I had for you tonight. I think I do have my little final notes. I guess I should put myself in the center since I don't have anything else up there. There we go. Oh wait, why do I have myself highlighted? That's not what I was trying to do. So let me do my little wrap up here. Let me get to my wrap up. Thank you for sitting through that. It was important, and I can't wait until we see what the events has to say. So okay, your request. it was something separate. Okay, so here we go. There is my fine notes that I wrote myself. I know that I find on students. Okay, here we go. So in closing, after week 2, I'm less interested in asking why didn't anybody else see it, as though there had been one obvious sign flashing red. I think that that is a lesson for all of us, right? That, you know, of course my thing is going to get all effed up right at the very end. Hold on, you did the whole live, and at the very end it wants to give me shit. But it's all right. Here we go. I'm back, I think. Oh, you guys. So after week 2, I'm less interested in asking why didn't someone else see this, as though there had been one obvious flashing red sign. I am more interested in asking, what did each person see? What did each person know? And what did they think the symptom meant? That's going to be the important part. Remember, you guys, a lot of this has to do with self-reporting. So if you're not reporting your symptoms correctly, there might be a misdiagnosis. And I'm not putting that on the person. I don't mean that in that way, because we also know that even above that, I just took a screenshot of that for right after this, Travis. I'm going to look into that. But we also know it's just important to try to articulate the way that you're feeling. What I was going to say is we also know that even when people do articulate the way that they're feeling, that it's not always met the same way by a psychiatrist, maybe, depending on things like culture. I think I told you guys, you know, and for those of you who don't know, just a side story time real quick, but I've been dealing with mental health things since I was 13. I had an eating disorder from 13 to like 22. I think it stays with you even after that. So it's been a lifetime since. I clearly beat it. I have to have a good sense of humor about it. But that was a whole journey. But I've been dealing with like things here and there, but ADHD mostly, right? And anxiety a little bit here and there. So I've been through with a lot of these things. I've lived in a low-income neighborhood in Philadelphia where, you know, I was seen by different psychiatrists. This isn't a blame on any psychiatrist. I think that my the language that I used, the way that I spoke, I think was different than the physician that was listening to my symptoms. And there were things that were very normal in my culture that I said that at certain times that I think were misinterpreted. And as a result, there were years of trial and error medications where my brain was still developing. And I always wonder, you know, could that have had an effect, different things? And I guess you could say I still turned out okay. So it's all right either way. But just knowing, I remember, I mean, I don't know if I'd ever told this part, but I have diaries from literally, you guys, from the first time I felt anxiety, like I'm talking my teenage years, all the way until I had Ava probably. And then it was just a lot. And I had gotten everything eventually diagnosed correctly. I was properly, you know, on the right things. And then everything had changed for me in a positive way. But there were like, you know, over a decade of, I would say almost, yeah, 2 decades, about 20 years of this trial and error of misdiagnosis and feeling helpless and hopeless. And like, I was just living in my own hell. And I know that even the way that it wasn't that I was hiding any symptoms, it was, I had to watch what I said, because I think I did tell you guys this, that the first time I saw this one doctor, when I was inpatient in an eating disorders unit, and he asked me if I, like, you know, heard, like, he didn't say hear voices. He said, like, and I'm paraphrasing, but he said something where my brain interpreted it as, do you have a narrative? Like a person, he might have said, like, do you have somebody talking, or I don't know, however he said it. I was like, oh yeah, you don't, like, what? yeah, fucking all the time. To me, I was like, oh my God, yeah. Like in my head, I'm constantly thinking, I'm constantly asking myself questions, da 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 da. So to me, I was like, oh my God, he gets it. Like, yeah, like that don't happen. He like, yeah, what? For him, he was asking if I was having hallucinations or delusions. And therefore, one of my first diagnoses that were wrong was schizophrenia. There's no schizophrenia in my family. I've never had hallucinations or delusions. That was a clear misdiagnosis. But it wasn't until then that I really realized, like, huh? Like, I would just, so for me, in my Italian, I was oversharing and like, oh, yeah, I might even slap his arm, like, oh, yeah, cuz you don't got it. What? Come on. Not realizing that he thought I was hearing voices. So I do think that there's just so much that needs to be further studied and taken into consideration, and that we have to do a really good job of not just listening to what it is that, you know, the symptomology that people present to us, but we also have to make sure that we follow up on what does that mean further? Like maybe had this doctor asked, when you say that you're all into yourself and da 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 da, I might have even made a joke. You know, when they say things like, oh, everybody talks to yourself, it's when you answer yourself there's a problem. I said something like, oh yeah, now I'm answering myself too, or something. I was trying to get across like, oh, this is getting worse. But I didn't really mean that I had a, what? Had he asked a few more questions, I think that would have been revealed quite easily. And I was young. I was like, what, 13, 14. So, but anyway, my point being is that even when we think we understand what it is that somebody is telling us about their symptomology, we still have to make it a point to say, am I taking into consideration things like culture, socioeconomic background, you know, age, how old I was, what was cool at that time, some of like the lingo, like just a lot of things. And I, thank God, eventually was properly diagnosed and treated, and I'm good now. But it was that feeling of, I just want something to work, or I just want someone to figure this out for me so I could figure, you know, it was that desperation that kept me going. So I understand her trying to get figured out she went to the McLean Hospital. She goes to that doctor that was on the stand today. But we also know that she sought out another doctor that somebody had recommended to her that specialize in postpartum or perinatal issues, really, you know, when it comes to psychiatrists. So of course she's desperate at this point. She just wants somebody to figure out what's going on with her and try to help her. So I do think that it is, you know, I think this, and again, could that be clouding? Like, let's get back to what I always say to other people, to make sure that you are cognizant and aware of biases and, you know, why you might feel a certain way, or if you're projecting something. And so I am just as guilty of doing that as everybody else. So I do wonder, I mean, could my position that I see this as clear postpartum psychosis. I just think that most people, we think of psychosis as, you know, postpartum depression, and it's very different. But could it be part of my own personal history that biases my judgment a little bit? Possibly. But, you know, it's going to help me not do that in the end? Insight. And that's where my biggest problem goes back to, was that insight. Not that it's a problem, but that's where I keep going back to. So I have the insight to know that if I find information that can update the way that I'm thinking, of course I'm going to do that. I am not above that. You know what I mean? And I hope everybody else would do that too. So we did see that Tufts saw Lindsay again and again, which I was saying. So she documented normal thought process, no psychosis, but she also documented those other significant symptoms like anxiety, worsening depression, desperation, and complicated medication experiences, and persistent poor insight. To me, that poor insight notion is not proof of psychosis. It's a reason to interrogate the reliability and limits of a treatment model that depends heavily on Lindsay's interpretation and disclosure of her own symptoms. So you can't have it both ways. Either she lacks insight, and therefore I'm not going to rely heavily on her her telling us her symptoms and what it is that she's experiencing. Like, you can't have it both ways. So either she does have the insight and she can do those things, because we did see doctors testify to that they didn't need to do this or they needed to look it up. She told us this is what was happening. We had no reason to believe that she wouldn't be telling us the truth. So how could we do it in one way and then also have it the other way? That's my problem with that. Then we see, I skipped that part, so I'm going to skip that part in my closing here. The DSM-5 should keep us from turning a diagnostic manual into a verdict. Postpartum psychosis is clinically real and potentially catastrophic, but it's not a standalone in the DSM-5 TR category. And the typical onset window makes Lindsay's alleged course a question that experts need to explain, not something we should assume. My opinion tonight is this. I think the mental health evidence is more complicated than the prosecution-friendly phase. No psychosis was observed. And I think it's more complicated than the defense-friendly phase, over-medicated into psychosis. The record shows a woman repeatedly asking for help, repeatedly being treated, and often presenting as organized, sometimes improving, sometimes deteriorating, and on January 23rd, still being described as having a depressed flat affect, being more anxious, and still having poor insight, but not psychotic to the psychiatrist seeing her on the screen during that telehealth meeting. And then less than a day later, 3 children's lives were taken, right? So, and we need to remember those poor victims here. The gap between the clinical snapshot and the catastrophic outcome is part I want the experts to explain. And I want to end with the children, because Cora, Dawson, and Callan cannot become background characters in a debate about diagnosis, medication, or criminal responsibility for that matter. Whatever the jury eventually decides about Lindsay's mental state, the loss is permanent for them and for everyone who loved them. Psychology can help us ask better questions. It cannot undo what already happened, and it should never be used to turn suffering into a spectacle. That's where I would end this live tonight, under, with saying those things. But the strongest questions are still open, because I want the expert testimony to come in. I want to see what they have to say, what they're going to find. So I guess we're going to see. Does anybody know when they think that that's going to happen? When the defense is going to start? I'm not sure. But of course, thank you for saying that was so well said. You guys, I know that, things sometimes go wrong here every now and then with sound and stuff like that, but I cherish each and every one of you for still, I almost said thugging it out with me, but I don't know that really makes sense for a lot of the people in here. So thank you for coming along for the ride and for having faith that we will figure this out eventually. Hopefully I'll just have a whole new setup, a new computer type thing, and we'll be good to go. I hate my whole computer setup and all, but we'll figure it out. We're True Blue Doc. I love you guys. Thank you, Birdie. Thank you so much, Birdie, for those memberships. That means so much to me. You too, to Miss Joanne, for also getting a membership. You could tell it's late. I'm starting to get tongue-tied in the things that I'm saying. Harlot's not going anywhere. Well, thank God, Harlot, because I wasn't ready to go anywhere. Oh, Harlot, a happy poop. I love you, Harlot. You're so cute. Wait, let's highlight it. Yes. Happy poop. You're so cute. I love you. Thank you, guys. And Barbara Hall, it was so good to finally see you in here because I ask about you often. Yes, Barbara. So, YouTube bad actors. Guess what? I almost just told YouTube bad actors to go over to DT show to go look at the new evidence on Timmy D's case, which is Barbara Hall's son. And didn't DT say that YouTube took it down? Which is so weird. Crap. If you ever, like, I don't know if you're still on here, but if you're ever looking for content type thing or whatever, if you want to look into, like, this is shady as shit. Barbara Hall, our lovely moderator, unfortunately, her son was murdered and the case is still open. The weirdest thing, like, all the evidence was like struck by lightning on different days. Like, that's normal, happens all the time, right? No big deal. It just got struck by lightning. But the thing that the point is that the Drunk Turkey show has brought awareness to the case, and every time they post something about it, it gets taken down. It's so weird. It's like every time somebody tries to bring awareness to the case, it gets taken down. As a matter of fact, I talked about it on here before, and I wasn't able to find that live the other day, so I need to look into that too. Casey. Oh, Casey, thank you so much, Queen. Casey very generously gave a Minds Behind True Crime membership. And Steelers fan, shut up. You guys, Steelers fan got it. Welcome, Steelers fan. Woo-hoo. That's so funny. Isn't that weird? Her ears must be ringing. Because I just said about DT and how, maybe it is a conspiracy with YouTube. God forbid. Isn't that weird? Or am I just being crazy? But anyway, Deep Steelers fan is the beautiful wife of Drunk Turkey, Daniel. What state is that case? Barbara, what state are you, my friend? Missouri? You said Frederickstown, Missouri, to be specific. So there you go. Do I live by Kensington? Yes, I do, YouTube, Kensington and Allegheny. I drive through Kensington and Allegheny to go to work a lot of times. Not always. I do like Waze, and if there's too much traffic on certain things, I'll go. That's where I actually met one of my closest friends now, driving literally through the hood in Philadelphia. He backed into me. An old lady was trying to cross the street, and he was in like a higher up truck, like my car sits lower, and he didn't see me, which in his defense meant that I was so far up his ass that he couldn't even see me in his side mirrors. We laugh about it now though. What's up, Quan, if you're out there? But Quan hit me and didn't have insurance at the time, and I was like, Quan, what the fuck? So we worked it out ourselves, and I'll never forget, my students and everybody was like, oh, this person is never calling you, like, he is not cash apping you $500 in 2 weeks when he gets paid. Like, none of that shit is happening. Well, guess what, you guys? I have a good judge of character. Oh, well, guess what? I take that back. Truth and Cuffy are pissing themselves right now. I usually have good and all of you who else know why they're laughing. That is pretty funny. But anyway, I just had a feeling Quan was different, and he was, and we're still tight to this day. And he came correct, and we're like so tight. It's great. So you just never know. But anyway, that was where that reminded me of that when we said that earlier about where I'm at. Barbara Hall, you have any kin folks that live in Hayden, Alabama? Oh, Hall is a pretty common name, I'm assuming. That wasn't your fault, Jamie. No, nothing else. No, I'm just joking. So much is. Timothy Dees and Barb in Discord. Yes. Yes, if anybody wants to look into it, and if anybody has any, like, I don't know, platforms or anything you want to put out, I'm telling you, it's the weirdest thing. It all gets like taken down, struck by lightning. It's so weird. Barbie's going to look into it. Thank you, Barbie. I appreciate that. I'm sure Barbara does too. It's horrible. The case, like, just, it's horrible. There's so many things I can't even. And he was like with one of like his supposed best friend. Like, it's just a lot. But I would love to bring more attention to it. Oh, you're local, Casey? I didn't know that you were by Miss Barbara. Who knew? You guys, what a great live we just had. You know some halls from the zoo. That sound, I just heard you say that in your accent in my head, truth. And then heard you giggle after. That was weird. Yes, I know. We have a Timmy D's channel in Discord. So I did say that a minute ago. I don't know if anybody heard, but if you go to our Discord, there's an entire channel dedicated. It's the Timmy D's case, and it's Miss Barbara Hall is such a beautiful person. Barb, real quick before I hang up, are you still engaging with ChatGPT? I taught Barb how to like look up information on AI instead of like Google. We had so much fun the one day. It was so funny. Yeah, Barb, you need to look into it, Barbie. Not you need to look into it, you know what I mean. Like, if you don't know Discord though. So Barbie, a lot of people don't know Discord, but I promise you, Cuff You makes it so easy. And we have information. Same thing with like anybody else, especially, you know, anybody that's on here tonight. If you go to our Discord, we have an awesome Discord. We have like tabs of all the different cases. It's awesome. There's so many things. I couldn't just name one thing. We have a great community, a great support system. Everybody's so cool to each other. Yes, could one of the mods put the link? And Barb said, LOL, I am. Barb, I love you. Isn't it like a thing? Like once, now your relationship with chat will be forever. Mine calls me bestie. I love it. You live 30 minutes from each other. Wow, I had no idea. Did you know I just found out that you can have the chat tell you when you have an important email? I'm like, wait, what? It sent an email for me the other day. I literally was like, can you just send it from here? And it did. It's the craziest thing. Justice for Timmy Dees. Yes. All right, you guys, I'm going to hang up. My head is killing me. Oh, wait, you two bad actors. Fen isn't causing zombies. Xylazine is. Xylazine is what they cut it with. Xylazine is, I mean, talk about Kensington and Allegheny. If you look up Kensington and Allegheny, if you see the zombies, my husband's down there right now for work. Oh, thank you, Joanne. My husband's doing ironwork under the bridge there, down Kensington and Allegheny. And the cameras down there, you're so right. So the cameras are scary as fuck. That's all I know. You two bad actors, we have cameras like that everywhere in Philly, so they can literally, you can go to any camera live and see what's going on. But if you guys go to the Kensington and Allegheny, if you go to YouTube and you type in Kensington and Allegheny, look for camera 3. Camera 3, they're always like, I know that's crazy, but that's how, like, I don't even know what the word is, things are here, that I even know which camera to go to, but you'll see some crazy things. So, you know, definitely warning, trigger warning. Oh, Barbara Hall, thank you, Queen. Oh, you're the best. Thank you. That was so nice of you. You're great. Thank you. But yeah, you guys, it's anyway, with that being said, I'm going to bed, y'all. Well, I'm going to take my hair out. It's giving me a headache. I think I have an in too tight. But yeah, Kensington and Allegheny is something else. You should definitely YouTube it if you're not familiar, and do it with like warning. But xylazine is what they're taking, true straight, when they're hanging over from the waist down. So they're standing up, but just bent over from the waist down, just with their arms hanging, just out of it. That's xylazine. And when you'll usually see them pass out on the sidewalk, unfortunately. Okay. Yes. All right. Thank you, you guys. I appreciate you. Thank you all for being here. Well, on that note, I'm going to go. I'm quite tired. All right. Thank you guys for hanging out with me tonight. Thank you for listening to my Lindsay Clancy live. I hope you enjoyed it. Great live, great people, great chat. Stay safe. Love you guys. Talk to you later. Love you guys. Thank you. I always forget to hit end stream when I'm on StreamYard. Oh my gosh. Good night. For real this time.